यही वाला सब खाली करते हैं।
So we are live now. I'll just give a brief intro and then probably we can start.
Others can mute their mics, please.
Just checking for the live, whether we are live or not. Just. Yes. Good morning, everyone. Today in Ulte, we are going to have a wonderful session from a beautiful country, Nepal. Probably it is one of the most beautiful country, and it should be in the wish list of each and everyone. Nepal Urological Association is a very new as compared to many other older association. It was formed, I think, in the year 2005. And we have the founder secretary here, Dr. Prem, with us. Today we are going to have 6 talks by the stalwarts in urology. All of them have made their mark in the urology in the short span. Nepal Urological Association consists of approximately around 120 urologists, and to our knowledge, almost everyone, 97 urologists are there in our group. So with this, I'll share the mic with Dr. Anil, and he will take the proceeding further. Thank you. Dr. Anil, please.
Dr. Anil, please unmute your mic.
Thank you, Dr. Nitesh. Firstly, I would like to thank Ulte Group for giving us this opportunity to come forward and share the ideas with our friends in India, Nepal, and all over the world. I think this is a very good platform, and it has picked up very fast in very short span of time, and we could utilize the time of lockdown by sharing our knowledge in urology all over the world. So without taking much time, I would like to introduce our speakers for today. The first speaker will be Professor Prem Gyawali. He's, as mentioned by Dr. Nitesh, he's our founder, secretary of National Urological Associations of Nepal. So he will be speaking on management of urolithiasis in COVID pandemic today. And he is mentored to most of the young urologists in the country. Second speaker will be Dr. Sanjay Khadgi. I think he needs no introduction, especially in India, Nepal, and of course in Europe as well. He's very known for so-called Chinese mini-piscian. I don't know why it is called Chinese. There's in literature, there's no Chinese mini-piscian. There is mini-piscianal, ultra mini-piscianal, micro-piscianal. Anyway, he's very well known in country and abroad for mini-piscianal. And we have requested him to speak on complication of mini-piscianal today. He has performed numerous live surgeries on
Dr. Anil, can I interrupt? Your slide is not changed.
Okay. So he's from Kathmandu. So third speaker will be Dr. Bhojraj. He's assistant professor of urology in TU Teaching Hospital, Kathmandu. He's very young, dynamic urologist of our society, and he has presented many papers, and he has contributed in publications of PCNLs in international journals as well. Fourth speaker will be Dr. Robin Bahadur Basnet. He's from National Academy of Medical Sciences, Bir Hospital, Kathmandu, working with me. We work together. He's an associate professor of urology, and he's very keen in doing research in PCNL, and he will be speaking in percutaneous nephrolithotomy in HER2 kidney today. Fifth speaker for us today will be Dr. Bipendra. Sorry, there is a mistake in spelling. Bipendra D.K. Rai. He's also from Kathmandu Civil Service Hospital. He's a very good orator, and he has finished his urology recently and joined a very central hospital of government and leading the department of urology. And he will be speaking on management of bleeding complications of PCNL. Lastly, I'll be speaking today on RIRs for lower pole stone. How is it different? I'm Dr. Anil Shreshta, working as an associate professor of urology in National Academy of Medical Sciences, Bir Hospital, Kathmandu. Thank you, friends. Dr. Nitesh, shall we start with our first presentation?
Yeah. So thank you, Dr. Anil, for introducing everyone. And just to add to you, you're also international, urologist of international repute now in RARS field. And thank you so much to all of you for accepting this invitation. Special thanks to Dr. Prem and Dr. Sanjay sir. And so, Dr. Anil, you can take the proceedings further with the presentations.
Thank you, Dr. Tanuj. So I request our Professor Gyawali to start with his presentation, and he will be speaking on management of urolithiasis in COVID pandemic. Sir, please.
Can I start now?
Yes, sir.
Yes, sir. Please go ahead.
Okay. Okay. First of all, I would like to thank Urology Learning through others experience team, Dr. Nitesh and Dr. Tanuj, for providing us this opportunity. Today in presentation, the following speakers will talk about the renal stones, how to remove the stones from the kidney, how to minimize the complications, and how to treat the complications. But here I'm speaking about management of urolithiasis during this COVID pandemics. So pandemics that has changed the history. Pandemics has changed the boundaries of the countries. It has changed the ruling dynasty of the countries. It has changed economics and business of the country. So the first recorded pandemics is 430 BC during the Peloponnesian War in Athens between Egypt, Greece, Cyprus. At that time, 2/3 population of the world was killed. And well-recorded pandemics is the bubonic plague in 14th century, when 1/3 of the population were killed. In 1889, Russian flu has killed 360,000 population in the Russia only. The latest pandemic is Spanish flu. Actually, Spanish flu was started in 1915 or 1916 because of the First World War. Many countries, they denied the presence of disease in their country. Only in 19th of May 1918, Spain declared that they have this disease, and they declared it as a pandemic. At that time, 50 to 100 million people have been killed. In India also, that was the droughtiest year in the whole history of India. And at that time, India has lost 10.6 million people. Even Mahatma Gandhi and Munshi Premchand were also suffered from the Spanish flu. Luckily, they recovered. And this COVID-19 has started recently. So at this era, we have to work with the urinary stones in the time of COVID pandemics. So COVID in 31st December 2019, in Wuhan, 3 cases of pneumonia were identified without any cause or the causative organism was not identified, but within 2 weeks, it was declared that it is the SARS-CoV-2 coronavirus. And within 3 weeks, after this first detected case, World Health Organization has declared it as a pandemic. Actually, SARS-CoV-2 coronavirus, it is enveloped virus and a lot of lipids on its surface. So disinfectant with alcohol and lipid solvents can easily kill those viruses. Not like the other viruses like rhinovirus, which is unenveloped and there is no that much of the lipid on its surface. So they are relatively disinfectant resistant virus. SARS-CoV-2 is mostly diagnosed with the reverse transcriptase PCR test. The sensitivity of the test is bronchoalveolar lavage is 93%, sensitivity with the sputum is 72%, nasal swab is 63%, and pharyngeal swab is 32%. Luckily, we are lucky, urologists are lucky that this SARS-CoV-2 virus is not identified in urinate. COVID-19 pandemics, once the government has ordered to minimize and suspend the schedule, elective operations or outpatient clinic, and it has jeopardized the management of non-COVID patients. Healthcare personnel are scheduled for duty, species, mainly the personal protection equipments, machines, and ventilators are kept free for possible mass admission with COVID-19. So government has ordered to minimize and suspend all scheduled elective operation. If we look in the graph in Italy, actually it is the Lombardy region of the Italy, which is the hardest hit by the SARS-CoV-2 virus. Once the government decided to minimize and suspend the elective admissions, the admission rate has gone like this, just near to zero. But the COVID-19 admissions were sharply increased. Similarly, in the next region. So overall in Italy, the admission rate during the period of COVID has gone sharply down, and they are the most affected country in the world who are fighting with the coronavirus. So urolithiasis in COVID-19, our main aim during this period is to free up inpatients' bed, because there will be the mass admission with the corona infection. We should free up the anesthesiology teams. We should free up the healthcare personnel. PPE should be saved, because even the developed country are suffering with the lack of PPE. Cleaning supplies and operating rooms should be free. The aim is to spare post-operative ICU care beds. If we do not operate the elective cases, because sometime after the elective surgery, patient may require the ICU beds, they may require the ventilator beds, extra PPE, and those ventilators will be engaged, and the really COVID patient may not get these ventilators, so elective surgery has to be reduced. To reduce the number of admission, we should screen all the patients who get admitted for the non-COVID infections. Just like if we are planning to operate in the patient with urolithiasis, this is actually Western criteria. They do screen with the RT-PCR test all the patients who undergo surgery. But in our part of the world, when government is suffering with lack of RT-PCR in the community, how it is practical in our hospital, we should decide ourselves. But in the Western country, all the patients who undergo the elective surgery, they should undergo the screening before admission. And we should try to minimize the virus dissemination and cross-infection in the hospital. If we read the publication by Lewis Robinson, he has mentioned in the United States, there are only 19.7 ICU beds for 100,000 population. In the United Kingdom, they have 16.6 ICU beds for 100,000 population. In France, 15 beds. In India, there is 3.2 ICU beds for 100,000 population. In Nepal, we have 5.5 ICU beds for 100,000 population. If we see for the ventilators, in United States, they have 32,586 beds. In United Kingdom, they have 88,100 beds. In France, 7,007 beds. In India, they have 40,000 ventilators. But out of 40,000 ventilators, only 8,000 ventilators are available in government hospital. Rest of the ventilators are in private hospital. In Nepal, you can say we have only 360 ventilators in a whole country. It means there is one ventilator for 80,000 population of Nepal. So according to the Jain et al. Who published in April in a New England Journal of Medicine 2020, what is written, the median age during admission of a patient with SARS-CoV-2 infection is 47 years. We all afraid of the fever. We are scanning the patient in the airport, in the entry points with this thermal gun, we are taking the picture. But you know, fever during admission are seen only in 43% of the patients. Yes, once they get admitted during hospital stay, 88% of the patient, they will have fever. 67% patient will have fever, and comorbidity with other diseases, 23.7% of the patients are admitted. Out of them, only 15% of the patients, they change into the severe illness with the SARS-CoV-2 infection. Abnormal CT scan is seen in the 86% of the patients, lymphocytopenia in 83% of the patients, and out of those patients, only 5% they require the ICU bed, and mechanical ventilators are required in 2.3% of the patients, and mortality rate is 1.4%. Here I have calculated, this is the Nepal national data. We can manage only the number of SARS-CoV-2 patients will not increase 7,000. According to the yesterday's report, there are already 102 patients detected in Nepal. Luckily, 100% of them are in this group. They are with the mild symptoms. But if 7,000 will suffer, according to the Wayland, 5,600 patients will have the mild symptoms. 1,050 patients will require the ICU beds. Yes, we do have that much of the ICU bed, but only 5% of those patients, 7,000. It means we can manage with the ventilator only 350 patients. So if the number of the patients will increase sharply, we will be overwhelmed and our system may be break down. So urolithasis during COVID-19, all the managed according to the capacity and demand of the country. Elective surgery term is vague. What is elective surgery? If you operate after 1 month, is it elective? Or if you operate after 1 year, it is elective. It is a vague term. And emergency term depends upon the capacity and demand. I remember where I did my post-graduation in Russia. Once a patient comes with diagnosed acute appendicitis, the patient must be operated within 2 hours after reaching the hospital, within 2 hours. But in our setup, we do wait for 6 hours, 8 hours. If the patient comes in the morning, in the evening, we can schedule in the next morning. So it depends upon the capacity and demand of the country. And patients should be prioritized according to the urological cancer or complicated stones. The priority should be given depending upon the progression of the disease, possibility of the metastasis, or possibility of the organ failure. And consideration should be included to surgical treatment until the demand of ventilator and inpatient beds will fall down. This is the algorithm from Italy that Silvia Proietti has published in this paper in European Urological Association journal. Once they have the scheduled patients in group, they prioritize according to the organ failure, possibility of metastasis, and the possibility of the progression of disease, and they screen the patient with phone call. And they invite the patient to the hospital, depending upon the priority. And if the patient has fever and surgery is emergency, they divide. If it is the surgery emergency, whether the patient is suspected with COVID or not. If is, the operation theater is dedicated for the COVID-19 positive, SARS-CoV-2 positive patients. And if it is not suspected, and they go in the regular OT. If it is not surgical emergency, medical consultation or ER visit or stay at home is advised. If patient doesn't have the history of fever, they take the history of the contact, history of travel history, any fever, or if they have any contact with the infected person. If is, then again they divide whether it is emergency or not. If it is emergency, then whether he is suspected as a COVID or not. If it is suspected, then they go for the dedicated COVID ward. If they are not suspected, they go to the regular ward. Such way they have prioritized the case. And another way how they prioritized is, if the patient comes, I'm talking about the urolithiasis only, okay? So non-obstructing renal stones, and the kidney is normal, and there is no solitary kidney, it is least prioritized, those patients. If stones are non-obstructing, but the kidney function is impaired, kidney is solitary, and ureteral stones with the indwelling stents or nephrostomy, they are the priority, little more priority is given to them. If the stones are obstructing, but the kidneys are normal, it is not solitary kidney, they are more prioritized. But the kidneys are obstructed, ureter is obstructed, there is infection, kidney is solitary, then it is highly prioritized. This way, they have prioritized the cases for surgery. So how the hospital should be prepared? Hospital should have one strategy: minimize as less as possible the hospital bed, use of hospital bed, use of hospital care staffs, use of PPE and operation theater, and minimize the use of post-operative ICU beds. It means the operation which are done in case of during the COVID pandemic for the urolithiasis should be operated by the senior experienced surgeon. Thus, the complication, post-operative complication is less with them, and requirement of the post-operative ICU beds and ventilator is less. For the prevention of the cross-infection in hospital, they have divided into people and environment. In the people, if patient is admitted in hospital, the movement is strictly controlled, and the visitors are not allowed in the hospital. For the healthcare worker, they are taught to use the occupational safety, appropriate PPE, and self-monitoring, and they have to report their health status to the hospital authority every day. About the environment, there will be no outpatient clinics, no training activities, no teaching learning program, and limited access to the OR. In the operation theater, only the experienced surgeon with the minimum number, experienced anesthesiologist, and experienced nurse are allowed. Decontamination of surface and objects are done. There should be enough space and social distancing during the surgery. Proper PPE should be used, and the operation theater should be well ventilated. This is the EAO guidelines recommended for SARS-CoV-2 infection. They have prioritized this way: low priority, intermediate priority, high priority, and emergency. Low priority, if we postpone the cases beyond 6 months, the harm is very unlikely. If we postpone the cases more than 3 to 4 months, the harm may be possible. If we postpone the case more than 6 weeks, definitely the chances of harming the patient is high. And emergency, it is life-threatening situation. Likely the patient will visit to accident and emergency department despite of current pandemics and the crowd of the patients with the SARS-CoV-2 virus infection, and patient do visit the A&E department. It means they definitely require they are the high prioritized patients. And they have given in the guidelines, if patient comes with acute flank pain, the imaging modality and laboratory modality are kept in high priority. And all type of the investigation like ultrasound investigation, non-contrast enhanced CT scans are being done, urine routine and tests are done depending on the high priority or emergency priority. They are not low priority cases. And if we see non-obstructing ureteral stone, they are non-obstructing, then medical expulsive therapy should be started. It is intermediate priority. And intervention should be done not by the removing of the stone, just by placing the double J stent, or if required, nephrostomy tube under local anesthesia. When the patient will not require the ventilator, they will not require the anesthesiology team, you can put the nephrostomy tube in outpatient and send patient back to home. If obstructing symptomatic ureteric stone and MET is not suitable, then intervention should be done. Which intervention should be done in such situation? Though I am not the fan of shockwave lithotripsy, I do not believe that much in the shockwave lithotripsy, but in COVID pandemic, as much as possible, we should send the patient for shockwave lithotripsy rather than doing the RIRS and PCNL. It is again to reduce the use of ventilators and use of the health personnel. Renal stones with a recurrent infection and obstruction, they come in the high priority. So first we should decompress it, and only after the decompression you should intervene in those patients. So from my presentation, the take-home message is minimize the occupancy of inpatient beds. Do not engage healthcare worker and ventilators. They will be required in other cases with SARS-CoV-2 infection. Prioritize the cases for operation on the basis of disease progression, metastasis, and organ failure. This should be your main target while you prioritize the cases for surgery. Keep social distance and proper PPE use. The Roman aphorism says, si vis pacem para bellum. If you want to peace, prepare for war. Thank you.
Thank you so much, sir. That was a very nice talk, and we learned a lot from it. Especially you gathered all the information practically available from urologists, which makes it very practical for us to use in our clinical practice. It's a privilege to have faculty like you on this panel, sir. Thank you so much. So
Thank you.
We'll take up the questions at the end of the session, sir, as a panel discussion. So please stay with us.
Sure.
Yeah. So
Thank you.
Dr. Anil, I would like to invite Dr. Anil for his talk. Please go ahead, Dr. Anil.
Thank you. Am I audible, Tanuj?
Yes, yes, clear.
Thank you once again, my friend Tanuj and Dr. Nitesh from ULTO Group and entire ULTO Group for this opportunity. Today, I'm going to speak on retrograde intrarenal surgery for lower pole stone. How is it different from other modalities, and how is it different from other stone locations in the kidney?
Your slides have gone away.
Slides gone?
Yeah, your screen share is not.
Is it there now?
Yeah.
Okay.
Yes.
So I don't have anything to disclose. So why we are talking about LP stone? Lower pole stone is different from other location of the stones anatomically, technically, and in terms of result of success, result of stone surgeries as well. Anatomically, lower poles are different because of the drainage and failure to pass the stone fragments spontaneously, especially in shockwave era. And also the technical details, technicality is also, there are some differences in technicality when we talk about RIRS in lower pole stone. So we'll be discussing today some technical aspects of doing flexible uteroscopy for lower pole stones, as well as some anatomical details. So when we talk about stone guidelines, there are almost all the guidelines from AUA, from EAU, And recently we have guidelines from Asia also. So all the guidelines, they primarily focus on stone size, whether the size is smaller than 10 mm, 10 to 20 mm, or more than 20 mm. Another aspects in the guideline that they mention is the type of interventions that is recommended for the particular patients. That is either ESWL, RIRS, or PCNL. Or the third aspect that they mention in guidelines is the location of the stones. And when they talk about location, it is only lower pole stone. When we talk about location of stones in guideline, it doesn't matter where it is, upper pole or mid pole. It matters only for the lower pole stone. So that's where we can feel the importance of lower pole stones in terms of management of kidney stones. So what does guidelines say? Guideline for lower pole stone, this is a recent guideline from EAU 2020, published recently in March, at the end of the March. If the stone is less than 10 mm in lower pole, the primary treatment modalities will be either ESWL or RIRS, and second option will be PCNL if less than 10 mm. If more than 20 mm, it's for every stone, both for lower pole and non-lower polar stone, first option will be PCNL, and second options will be either ESWL or RIRS. So if the stone size is in between 1 to 2 centimeter in lower pole, if there is no unfavorable factors for ESWL, then we should consider for ESWL. And at the same time, RIRS and PCNLs are also viable options at the same level. But if there are unfavorable factors for ESWL, then RIRS should be considered, and PCNL is kept as a second option. So we have noticed that RIRS is standing very strong in almost every stone size and locations, except for the stone size more than 20 mm, where PCNL is the first treatment option. So from this, how the guidelines are developing, from the development of guidelines, from the evolutions of guidelines, what we can understand is RIRS is securing very strong place in the management of renal stone, both lower pole and non-lower pole stones. So when we talk about lower pole stone, so why RIRS is indicated or recommended, and how is it different from other treatment modalities or locations, and how to make it efficient and safe? These are the questions that I'm trying to address in today's presentation. So when we talk about stone surgeries, we mainly have three modalities like ESWL, RIRS, and PCNL. So our aim of any stone surgery should be to achieve highest success with minimal morbidity. So when we talk about all these three treatment modalities, it has been proven and it has been shown from many systematic reviews and meta-analysis that ESWL has comparatively low success rate, but it has very low morbidity as well. So low success rate, sometimes below 50% of success rate, is not acceptable when we talk about stone surgery success. When we talk about PCNL, I think PCNL has got highest success rate among all these three, and it has got morbidity also. So when we talk about when we compare all these three stone surgeries, I think PCNL has got highest morbidities, longest hospitalization, and needs of transfusion and embolization as well in very small group of patients. Whereas RIRS maintains that balance of high success rate and minimal morbidity. That's why it is being popular among patients and among surgeons as well. So how to access the lower pole when we want to treat the stone in the lower pole? If the lower pole is small, non-dilated collecting system, then just by deflecting the deflection lever of the flexible uteroscope with active deflection, it is easy to access lower pole unless infundibulopelvic angle is very narrow. So when the collecting system is not very dilated, active deflection works. So when the collecting systems is very dilated, there is a moderate hydronephrosis, moderate to severe hydronephrosis, then active deflection may not work, especially when it is combined with sharp infundibulopelvic angle. So in this condition, combination of active and passive deflection should be done to access the lower pole. What does that mean? Passive deflection is, active deflection is achieved by deflecting the deflection lever, whereas passive deflection is achieved by pushing the flexible uteroscopes little further inside the kidney, and when it hits the kidney wall, then it passively deflects and enters the lower pole. That's how we can introduce our scopes in dilated collecting systems with sharp infundibulopelvic angle. So these are some tips. So in ESWL era, there has been lots of debate and research regarding what are the unfavorable factors that hinders the passage of stones, or that hinders the success rate of shockwave lithotripsy from lower pole. Does it apply in flexible uteroscopy era? Not actually, not similarly, I would say. There has been some factors that has been extensively studied that hampers the passage of stones and stone fragments from lower pole, like lower pole anatomy, infundibulopelvic angle, infundibular length, infundibular width, etc., etc. But the problem with assessment of lower pole anatomy, specifically infundibulopelvic angle, the problem with it is there is no standard technique. There are various techniques described in literature. The first one to describe was Albanasi, and the method of measuring the IPA according to him is not very easy. Later, Sampaio described his own technique, and Dr. Narmada Gupta from India also described his techniques, where he used two angles, angle 1, angle 2, for measurement of IPA. There is a paper from Nadia group, Sabni sir, he has also described his own technique. But all these techniques are different. All these techniques are not standard till date. It's not been validated so far. The problem with them is it is difficult to reproduce this measurement. You know, it's difficult when it is measured multiple times. You can get different angles. And another thing is there is no definitive cutoff value, which angle is, below which angle is not good for success rate of the particular stone surgery. So another problem with measuring infundibulopelvic angle is what are the images that we use for measurement of IPA, whether it is preoperative IVU or CT IVU or intraoperative retrograde pyelogram, and how much contrast do you use to delineate the PCS, because distended PCS may give different angle in the same kidney. So there are flaws and there are drawbacks in measurement of infundibulopelvic angle. That's why it's not very widely used, though we see papers coming up on measurement of IPA and success rate of ESWL, PCNL, RRS, etc. So what we should remember when we treat a lower pole stone is with our scope, flexible scope, is anything inside the working channel will decrease the deflection of the scope. Apart from that, the age of the scope is also important. If your scope is getting older, then the deflection is going down. So these factors are should be kept in mind. So to be more specific, if you want to use any baskets or any laser inside the working channel, that will reduce the deflection of the scope, and that may be problematic when we treat the lower pole stone. So always remember to use smaller laser fiber that you have in your OR for treatment of lower pole stone. We prefer using 200 micron laser fiber and 1.5 French nitinol basket, which gives least loss of deflection of the flexible scopes. So which fiber to use? What are the laser setting for lower pole stone? Do we have separate laser setting for the lower pole stone? That's another question. And as we have mentioned that use smallest fiber because it will cause less loss in deflection of the scope. Not only that, from one paper from the Europe, they have found that the smallest fiber are resilient to breakage. I mean, they don't break easily if we use less than 300 micron fiber, and it will not break easily in comparison to 365 micron fiber that is used for lower pole stone. Apart from that, there are few recommended laser setting for treatment of lower pole stone. It is recommended not to use high energy, because if you use high energy, more than 1 joule for the treatment of lower pole stone, it will produce more heat, and the chances of breakage of the laser fiber at the bending points is high. So what they have recommended is use of smaller fiber, less than 300 micron fiber is good for the treatment of lower pole stone. Low energy and long pulse should be used to save the laser fiber from breakage and subsequently damage of our flexible scopes. So use of larger fiber, high energy, short pulse, and short curve diameter curves are not recommended because it may cause fiber breakage. So which scope is good for lower pole stone? Because we in our part of the world we don't have much choice of selecting the scopes, but if you have to choose one scope for your practice that works for upper pole, mid pole, and lower pole, then you should have a reusable fiber optic scopes. Because so see, it is very difficult to prove in practice in patient that which scope is good in difficult cases, because we don't encounter difficult cases every day or so frequently. But there is an experimental study from Petra Group in 2017, and they have checked the different scopes in a lab, and they have found that flexible scopes of fiber optic type from Karl Storz is the most flexible one. And we have enough evidences from live surgeries and from our practice also, that when you have difficulty accessing lower pole, difficult location of lower pole stones, if you are working with your digital scopes or single-use scope, if you change it into a fiber optic scope, then many times we are able to reach the stone and complete the procedure successfully. And among fiber optic scopes also, the one from Karl Storz X2S is the most flexible one. So if you are to buy a single scope for your practice that works well for lower pole and all locations, then our recommendation will be to get a scope from Karl Storz Flex X2. So this is another very handy tip that I want to demonstrate is there are slight variation of fiber optic scopes from different companies. The upper one is a Flex X2S from Karl Storz. See, when we deflect the deflection lever, and in the deflected state, if we leave our thumb, then the scope remains deflected. This is very useful for treatment of not only lower pole stone, but especially lower pole stone. If you deflect the stone lever and leave it, then the scope remains in the lower pole. You don't have to keep deflecting the lever. That will cause the pain in your thumb, endoscopist thumb, you know. So if you have to work in the lower pole for the long time, then the Flex X2 is more ergonomic, I should say. Whereas the similar scope from Olympus URF P7, it's also a fiber optic scope from Olympus. See, if you leave the lever after deflection, if we leave the lever, I mean, if you go away the lever, then the scopes comes straight. So it may come out from the lower pole. So if you have a choice, if you have both the scopes, if you are treating lower pole stone, and if you have some pain in thumb or wrist, then I would recommend using Flex X2. So there is a saying that the time spent by any scope in the lower pole is inversely proportional to the scope life. That means if we treat more lower pole stone by a single scope, then there is a chance that we break the scope very soon. So from one survey, that it was found that more than 28% of the scope damage was because of excessive torque by the surgeon. So from this, what we can learn is, if you have to treat lower pole stone, why don't we relocate to save our scope, to make the procedure easy? And this is very unique features of RIRS. You convert lower pole stone to non-lower pole stone, and all the disadvantages of lower pole stones goes away when we relocate the stone within 1 minute. If you pick up the stone from lower pole and if you put it in the middle or upper pole, then straight away it becomes non-lower pole stone. The clearance goes up, your scope and your laser fiber can be saved. So I personally find these features of RIRS very striking and very useful. So, but the question is there any benefit in terms of stone free rate when we talk about relocation of the stone from lower pole or not? So when we relocate the stone from the lower pole, we are relocating for the good. We are relocating for the good in terms of stone clearance, in terms of scope life, and in terms of ergonomy also. It's not easy to work with the deflecting scope in the lower pole for the long time, for us, for surgeon as well. But when we relocate the stone from the lower pole, what we should remember is not all upper calyx are the favorable upper calyx. So when we treat lower pole stone, before relocating, what we recommend is, what we do is, we inspect all the calyces before relocation, and we determine, or we decide which calyx is most favorable in terms of passage of the stone fragments post-operatively, and also for the ergonomy of the surgeon. You can see if you relocate this lower pole stone in the upper pole, then you have to work in very uneasy and very uncomfortable position of your wrist, which may be, not good for your wrist if you have to work for like 45 minutes or 60 minutes in that position. So if you inspect the calyx beforehand, and if you decide which calyx to relocate, then you can work for next 45-60 minutes with very comfortable hand. So decide where to relocate the stone beforehand. And remember, not all upper calyxes are favorable. Sometimes middle calyx, and even sometimes minor calyx of lower calyx, can be very favorable for your hand and for subsequent passage of fragments. So it is very important to decide where to relocate the stone. Sometimes after relocation, it has happened to me that after relocation, I found that upper calyx was more unfavorable than the lower calyx. I had to change the position of the stone, basket it in the middle calyx, and finish the job. So upper calyx can be sometimes very unfavorable. There was very interesting study from Anup Patel from UK, 2018, published in Journal of Urology. He has demonstrated very novel technique, though it was not popular and it is not practiced actually, but I found it very interesting. After relocation of the stone from the lower pole, he demonstrated that injection of autologous 5 to 10 ml of autologous blood in lower pole, and when we let it clot and we finish the fragmentation and dusting of the stone in the upper or middle calyx, then the lodgement of stone fragments and stone dust in the lower pole is prevented and stone clearance is achieved better. So, but in the literature, there is not enough evidence whether in situ or displacement of lower pole stone and subsequent dusting and fragmentation, which method is better. In 2002, there was a publication by Shreshta, and he has they have compared in situ versus displacement technique, and concluded that displacement technique is associated with better stone free rate. But the problem with this publication is most of the stone size were more than 75% of the stones were less than 1 centimeter. And in 1 to 2 centimeter group, there are only 14 cases out of 78 cases. Only 14 cases were there in 1 to 2 centimeter group. And they have used two energy sources. EHL was also used, so there is some bias in energy used. So the result may not be very accurate. So it is too early to conclude with this size of sample. And after 2002, there has been tremendous development of scopes. There has been significant development of scopes in terms of digital scopes, flexibility, and vision of the scopes. Not only that, we have better lasers, we have better baskets. So to rely on this paper in 2020, I don't think it is a good idea. So with this in mind, we designed a prospective study in our department to see whether relocation is better or in situ dusting is the same, gives same result. So actually, it's an ongoing study, and we have done around 40 cases, and with preliminary result, we have found that there is a slight better stone-free rate with relocation group when the stone size, stone volume, and HU in the both group are comparable. So even if you can't relocate the stone, and if you have to dust or if you have to treat the stone in lower pole because of various reasons, because of inability to do basket, if you don't have basket, or because of various reasons, then you can dust the stone in situ in the lower pole. And what we can do is we can flush out the dust at the end of the surgery, by very gentle manual pump or very gentle irrigation. And all the fragments and all the dust from the lower pole can be flushed out into the pelvis or upper middle pole, or even sometimes even into the ureter. If you have made fine dust, if you have created fine fragments, then it is very easy to flush out those dust and fragments from the lower pole and make the lower pole free of dust and fragments. So this is very useful tips for treatment of lower pole stones and reduce the residual fragments and recurrence of the treatment of lower pole stones. Thank you. Tanuj?
Yes, thank you, Dr. Anil, for your excellent talk. And it was wonderful listening to you, and your tips for the lower calyx were really very good. Now we'll go to our next speaker. Our next speaker is Dr. Robin Bahadur. Hello?
No, is it Robin or it is Sanjay Kharge?
Dr. Sanjay is speaking on complication.
Yes, so first we'll finish other topics, then complication. Yes, Nitesh.
Yeah.
Fine, fine.
So, and the next talk is by Dr. Robin Bahadur on percutaneous nephrolithotomy in horseshoe kidney.
Thank you, Nitesh. Is my slide visible? Yes, yes.
Good morning, everyone from Kathmandu. I'll be talking on percutaneous nephrolithotomy in HER2 kidney. HER2 kidney. Before starting, I'll give a quick review on the embryology of HER2 kidney. HER2 kidney was first described in 1522 by Da Capri. And if you go to the embryology, we all know that the kidney develops in the upper sacral region at the region of S1, S2. The parenchyma develops from the metanephric mass of intermediate mesoderm, and the collecting system develops from the ureteric bud from the mesonephric duct. This is in the fourth week of embryological development, and within the kidney starts to ascend by the 7th week and reaches its final position by 8th to 9th week. And during its ascent, there is rotation of the kidney, and as well as the kidney starts to get a new blood supply from the aorta. But in case of HER2 kidney, the exact etiology of HER2 kidney is unknown, but various factors contribute to the development of HER2 kidney, such as abnormal ventral flexion of the embryo, abnormal rotation of, by abnormal rotation, we mean abnormal rotation of both the kidney or the embryo, because HER2 kidney has been widely seen in patients with scoliosis, vertebral agenesis, hemivertebra, spina bifida, etc. Or it could be because the kidney is arrested by alteration in position of the normal arteries, especially the umbilical and iliac arteries, or it could be due to delayed straightening of the embryo. About in the HER2 kidney, the two kidneys, they can be joined by a thin fibrous band to the thick parenchyma, and the thick parenchyma could be due to abnormal metanephric blastable migration, which makes the thick parenchymatous isthmus. Or this also has also been found with other genetic and autonomic disorders, like it is common in patients with it is common in patients with Turner syndrome, Edwards syndrome, Down syndrome, etc. So the classical teaching, what we have been taught is the ascent of the kidney, the isthmus is arrested by the inferior mesenteric artery. But in large studies, they have shown that the kidney is arrested by the inferior mesenteric artery in only 40% of the cases, whereas it is above the inferior mesenteric artery in other 40%, or the kidney could be well below the inferior mesenteric artery. But here we are only dealing with the PCNL. Another is what we encounter in HER2 kidneys is rotational anomaly. In this picture, we can see that in this am I audible?
Yes, yes, you are audible.
You're audible, sir.
In this picture, in this slide, I've kept two pictures: the posterior view of the HER2 kidney and the anterior view of the HER2 kidney. So what this has practical importance. If you see the kidney from the posterior view, what we see is only the parenchyma of the kidney. Whereas if you see from the ventral aspect of the kidney, the collecting system and the vessels, they are from the ventral aspect. So most of the blood vessels, abnormal blood vessels, aberrant vessels, accessory vessels, they are mostly in the ventral aspect, except some blood vessels to the isthmus. That is one thing. Vascular anomalies has been described by many authors, and these are mostly for theoretical use. But for practical use, what we should understand is there may be abnormal vessels from common iliac, from internal iliac, from median sacral, all the vessels around the kidney, but most of them, they arise from the ventromedial aspect. And similarly, there can be all sorts of collecting system anomalies, uh, uh, and if you see the pictures on the right side, these had been described by Dr. Sampalo from Brazil. He made three-dimensional polyester resin endocast from different kidneys. And if we see the upper one, that's from the horseshoe kidney. So the collecting system, it's somewhat, it is in a straight line. The collecting, the calyces are faced dorsally, dorsomedially, or dorsolaterally in cases of horseshoe kidneys. Whereas in the picture on the right lower side, that is the endocast of the normal kidney. The calyces, these are the normal calyceal anatomy. Coming to the diagnosis of horseshoe kidney, we all urologists must have seen horseshoe kidney in our lives. We can suspect a horseshoe kidney from a plain X-ray itself. We can see in this picture, there is a low-lying kidney shadow closer to the vertebral column. The lower poles are slightly medial. From this, we can suspect the presence of horseshoe kidney. Ultrasound shows the isthmus. A contrast radiogram, it can show the presence of parenchyma if it is a thick parenchyma, and the anatomy of the abnormal anatomy of the collecting system facing dorsomedially or dorsolaterally. Similarly, in CT scan, we can see the presence of isthmus, and in the radionuclide scan, we can see a continuous band of the isthmus if it has a functioning parenchyma. So, in our clinical practice, horseshoe kidney, it is associated with more chances of urinary tract infection. Urinary tract infection could be due to stasis of urine, or could be ascending infection because of concurrent presence of vesicular-ureteric reflux, which is common in horseshoe kidneys. So urinary tract infection, it is around 24% higher than the normal population in horseshoe kidneys. Similarly, around 20% of patients with horseshoe kidney, they develop nephrolithiasis. It could be due to stasis of urine. It could be due to more chances of infection. Horseshoe kidney, it has been found more commonly in presence of medullary sponge kidneys, which is also another cause of increased chances of nephrolithiasis. As well as recent studies, they say that these patients, the syndromic patients, they have got more chances of hypercalciuria, hyperoxaluria, hyperuricosiuria, or hypercytaturia, which all contribute to nephrolithiasis. Because of anatomical iodide in ureter, or due to more chances of PUJ obstruction in these patients, around 30% of them, they have hydronephrosis. So coming to the management of nephrolithiasis in horseshoe kidney, although open surgery, they should never be condemned, but open surgery is almost being obsolete in the present days. Coming to the minimal invasive surgery, some authors, they have described laparoscopic surgery for the removal of stones in horseshoe kidney. But laparoscopic surgery in horseshoe nephrolithiasis, it is advised if we are concurrently treating PUJ obstruction, which is common in horseshoe kidneys. Then next, a group of authors, they have described ESWL as one of the, they have said ESWL is favorable in horseshoe kidneys. But if you look at their literature, they have stone clearance of 50 to 79%, around 53% in an average. And the recent authors, they have favored RIRS. But the problem with RIRS is, as I said, horseshoe kidney, they are associated with eye riding ureter into the pelvis. So it may be difficult to navigate the scope into the collecting system. And similarly with ESWL and RIRS, because of the eye riding ureter, the dust particles of the stone, it will be difficult to flush out. So there will be more chances of recurrence of the stones. So now I'll be talking about PCNL. PCNL in horseshoe kidneys, it has been described by most authors. It is practiced worldwide as one of the gold standards for management of nephrolithiasis in horseshoe kidneys. Authors, they've described the stone clearance rate to be 72% to 98% in the first sitting. So that is the advantage of PCNL. The disadvantage compared to RIRS is if we are concurrently treating the PUG obstruction endoscopically, it is more difficult with PCNL than with RIRS. In PCNL, we have to go antegradely. In RIRS, retrograde management of the PUG obstruction is easier as described in literature. Now talking about PCNL and horseshoe kidney, I'd like to show some slides about what we have done in our department. I'd like to give a brief audit of our cases from 2015 April to 2019 March. 4 years, we had a total number of 691 PCNL, out of which for these, I've excluded the cases that we are not frequently doing or the difficult ones. So fulfilling the criteria for this, I've taken 627 PCNL cases, out of which 579 were non-horseshoe kidneys and 48, around 8% were horseshoe kidneys. Now, the occurrence of horseshoe kidney in normal population is around 1 in 400, that is around 0.25. So we may say, how did you get 8% cases? The probable reasons are, number one, as I said, the chances of nephrolithiasis is higher in horseshoe kidneys. So that could be one of the reasons. Another is, I took this data from Bir Hospital. It is the central referral center of our country. So we get more referral of difficult cases. The other surgeons, urologists who have thought that this would be difficult have referred their cases. So we had a total of 48 cases. That makes around 8% of the cases. Now comparing the patients with comparing the two groups, what I found is the patients with horseshoe kidneys, they are quite younger, with mean age of around 27, and non-horseshoe kidney around 37 cases. That could be because there is more chances of nephrolithiasis in horseshoe kidney, especially in younger age groups. So that could be the reason. The BMI was similar in both the groups. The importance of BMI in this is, if you go through the literature, we see that because the kidney is abnormally placed lower, large amplacid may be needed. But we did not have obese patients in our group, number one. Number two, our population is quite, they have got quite short stature than compared to the Western group. So none of our patients, we needed a longer amplaz. All of these cases were done with normal amplaz. Male, female, gender were similar. Both group laterality is similar. Stone burden was similar. It was lesser in horseshoe kidney, but statistically not significant. Number of calyces involved was more in non-horseshoe kidney. So when I went back and then checked the calyces involved in these two groups of patients, what I surprisingly found was there were very few cases with stones in the upper calyx in horseshoe kidneys, and compared to the non-horseshoe kidneys, horseshoe kidney as a whole. Stone density was similar. Solitary stones were more in non-horseshoe kidney. It could be because of more number of secondary stones due to PUC obstruction in horseshoe kidneys. Surprisingly, we did not have any cases of full staghorn in our orso population. We had 13 cases of partial staghorn. All of these patients, all of the PCNL were done in prone position, and after retrograde opacification of the collecting system. And for these, we used both standard PCNL or mini PCNL. They were used interchangeably in both the cases. I have not compared the complications and different things in these two populations in between the standard and mini PCNL. So these were the cohort work. The two groups were similar, and when we analyzed, we found that in horseshoe kidneys, in 48 horseshoe kidneys, 47 of the cases we went through the upper calyx, and only one case we went through the middle calyx. And
yeah, can you little bit increase the speed of the presentation?
Okay, thank you.
Thank you.
And then going to the upper calyx, it was quite easier. Why we went through the upper calyx is because the calyxes, as I said in the anatomy, they were facing dorsally, and the posterior calyx were more superior. There was more space to work on because the kidney was placed lower. We are not afraid of the vascular anomalies because most of the vascular anomalies, they are in the lower side. They are in the ventral side. So it was the upper calyceal puncture was easier, as well as upper calyceal puncture. It has been described as universal puncture because we can go through the different calyces, as well as we can go to the upper ureter. The access time was similar. We did not use multiple tracks in any of our cases. Operative time was similar, and stone-free rate was similar in both the cases, slightly more in the patients with horseshoe kidneys. Complications was also similar. Complications were also similar. Now, classifying the complications, all of the complications with horseshoe kidney, they were either clavin 1, 2, or 3A. We did not have, we had 5 cases of 3B bleeding, which needed angioembolization in the non-horseshoe kidneys. So that was our study. When I went through the different literature, this was quite old, published in Egyptian study, published in 2004. They also have a similar findings, single tract, less number of complications, and stone free around 82%. Another a Pakistani study with stone clearance of 83% with more number of upper calyceal puncture. Another article published in Journal of Endourology, where they have used we use all of our cases. We used rigid nephroscope. They used flexible nephroscopy, but even with flexible nephroscopy, their clearance was similar to our study. This is another study, but in this they have favored middle calyx. We favored upper calyx. This is a study from Pune, India, Manipal, and they have got a very excellent result with stone-free rate of 87.5%, no intraoperative complication, and only 2 patients out of 24 renal units that clavin 1 complication. And recent studies, recent journals, they have also advised for supine percutaneous nephrolithotomy. The most recent article published in, it is not published in Journal of Endourology as yet, it's visible online only, a multi-center study with 10 years of study comprising 12 centers, 106 renal units. They have compared both supine and prone position. In supine position, they have said middle calyx is easier than upper calyx approach. And time taken is lesser in supine approach, and they have surprisingly said with supine approach, the clearance in primary operation is primary PCNL is better in supine position. So this is not a take-home message. We are all watching from home. The message you can take at home is, although fraught with danger of complications, percutaneous access is very easy in cases of horseshoe kidney. You've got more space to work on. The upper calyceal puncture, it has to be quite, we find that it is quite medially placed. We may have to go through the tough muscles, erectus spinae and quadratus lumborum. We may require a little bit of more force, but it's very easy. The stone clearance is very good, and we should not be frightened with complications. There are very few complications with horseshoe kidneys. Thank you very much. This is Kathmandu at present. Thank you.
Thank you, Dr. Robin, for that excellent presentations. We have some questions for you, but we will be taking them at the end of all talks. Can you stop?
Yeah. Thank you, Tanuj.
Dr. Tanuj, can I suggest one thing?
Yes, sir, please.
Yeah, we should suggest the speakers to stick on the time.
Yeah, I have texted everyone personally about that, sir. And I would again request everyone to please stick to time and to the topic. So can I request Dr. Sanjay Khadgi to please start his presentation? Sir is a well-known figure. He has an immense following, including in India, and he will be talking about the complications of mini PCNL. So your mic is on mute, sir.
Am I audible to you?
Yeah, yes, clearly.
Okay, very good morning to everyone. First of all, I would like to thank the organizers giving me this opportunity to talk about the complications of mini PCNL. Actually, it's a broad topic to complete in 15 minutes. I'm sure Dr. Bipin will elaborate more on the bleeding, and Dr. Bhojraj will talk on the sepsis. If you have seen the guidelines, recent guidelines after treatment of stone, there is no word like mini PCNL modality. So here I'm talking about the mini PCNL technique and its complication. If we go with the complication, it's almost same whether you are doing the conventional PCNL or mini PCNL. The only thing we can minimize the complication rate. So this is a paper I have taken from the cross data published in Journal of Endourology in 2011. If you see the overall complication rate in conventional PCNL, that is somewhere around 20 to 25%. Sorry. And this is another paper, journal from the Turkey. Complication of mini PCNL is somewhere around 12.9%. This is my own paper published in Journal of Urolithiasis. If you go with the mini PCNL technique, we can have the complication rate somewhere around 7 to 8%. Out of this 7 to 8%, about 5% will fall in the complication in Clavin grade 1 and grade 2, and only about 1 to 2% will fall in grade 3 or 4. That is not very much high complication rate in mini PCNL technique. So as the complication, it is almost the same as I mentioned. I'm sure Dr. Bipin will highlight more on the hemorrhage, and this Dr. Bhojraj, he will talk on the sepsis. I'll take from the clinical aspects more on that. See, bleeding, it may be acute or delayed bleeding, which may be the dreadful complication during PCNL or mini PCNL. Well, there are certain factors, medical factors or the surgical factors, again, anatomical issues and technical issues. I have taken some of these slides from our Guruji, Dr. S.K. Pal, who is the master of master in PCNL. Well, people have concept that when we go with the smaller tract, the transfusion rate is somewhere around 1.5. If you go the tract size with the larger one, transfusion rate is much more higher. It does not only depend upon the size of the tract. The most important is how you make an initial puncture. So here I have taken one paper. This is in 43 patients who underwent needle biopsy with the 18 gauge needle. Even on the puncture, with the needle, this patient may have to learn further embolization. So what is important? Important is to know the vascularity of kidney, and this is for the clinical aspect as the 57% posterior segmental vessel artery crosses in the posterior aspect of the superior infundibular junction. As we all know, this segmental vessel, they further divide into lobar arteries and then interlobar and arcuate. If you see the relation with the calyx, this is clinically important. If we go to the fornix of the kidney, we can have the minimal bleeding, whether you perform the conventional PCNL or mini PCNL technique. These are some of the anterior surface and posterior surface. If you see the posterior view, there are minimum blood supply, and we are very lucky that as we perform PCNL from the posterior aspect of the kidney. If you see this, middle portion is more vascular than the periphery. So when you make an initial puncture from the more peripheral part, it is less bleeding. So if you see these vascularities, every kidneys, every human being has so much variation. I just want to give information that if you go more middle part, it is more vascular and it is more dangerous when we do mini PCNL. So in a puncture through a fornix of calyx, no artery injuries was detected, but minor vessel injuries were noted in fewer than 8% of the kidneys. Puncture through the infundibulum of a calyx produces maximum number of vascular injuries. And I would like to show you this video, the very important step, whether you do conventional PCNL or mini PCNL, is when we go through the fornix of the kidney, then we will have a clear fluid and the bleeding and other complications are much more less. Thus to prevent bleeding, skin puncture should be as lateral as possible. Needle should be directed towards the fornix and never at infundibulum. Never ever puncture the infundibulum of upper calyx. So our aim, whether you make a puncture through the upper pole or the middle pole, our aim should be through the fornix of the calyx. So sometimes we may have to do multiple punctures. So we should not hesitate doing multiple punctures. Even in a multiple punctures, whenever we go through the fornix of the calyx, we can have a clear fluid and the procedure will be smooth and complication is much more less. In my regular practice, once I get a fluid in my initial puncture, I always inject about 5 to 7 cc of contrast just to check whether this needle has not crossed through the major vessels. If so, if we have detected some major vessels while puncturing, then we have to manipulate this needle, either pull back or some angle change in the angle. So make a straight, short, well-aligned tracks to avoid tearing of renal parenchyma. As you have seen, I prefer to use these facial dilators starting from 10 or 12 and then go with the 18 French. which is very important. With these facial dilators, we can just advance the dilator in clockwise and anti-clockwise direction, and we should avoid we should do the gentle manipulation, and then we can have a clear fluid like this, and procedure eventually will be very smooth and complication will be much more less. So as I already mentioned, whenever we have to do multiple punctures, we should not be scared, and it should be done. The very important is precise puncture, and the tract dilation is utmost important. So the other way to avoid the multiple tracts is, if we see some calicial stones, we can just push with the needle, saline push, make the saline push, and this is how we minimize the multiple tracts, and this is how we minimize the complication rate in mini PCNL technique. This is, I already placed the tract from the middle calyx, and these small lower calyxes stones were there that were just pushed by the saline, and this is how we minimize the multiple tracts. So I'm not going to list, it is the same that I have explained all these things. If we have a severe bleeding, like more than 300 and 400 clots at a time, when patient have a bleeding, then the only way is to go with the renal embolization. Now coming to the pleural and lung complication, these are the list: pleural effusion, atelectasis, hemothorax, and injury to the lung parenchyma. So it is impossible to avoid supracostal punctures completely. We must learn how to utilize the pleural space intelligently to gain entry to the superior calyx without injuring the parenchyma. If you see the pleural reflection, how it going from middle to the lateral part of the thorax, if you see it passes in between the 12th rib and passes up from the lateral aspect, which we have to keep in my mind the clinical use. This is a paper about the supracostal puncture. Yes, when we go through the supracostal puncture, we may have around 15 to 30% of the complication rate. So this is again another paper. Supracostal approach for PCNL is the 10th and 11th intercostal space, safe according to the Clavin classification system. If you see this, many people talk about the supracostal. Many of them, they do not mention at which point, what is the safest point. This is also a supracostal, and even this one is also supracostal, supratane. So these are the 2 points. These are completely safe. The only thing, the direction and the angle should be very less as you go more medially. Well, this is about the CT scan after the PCNL. CT scan does not alter management protocol in majority of cases. Most of the patient get managed conservatively. So when we are precise in puncturing, then our pleural complication that can be reduced up to 1 or 1.1%. This is my own patient's chest X-ray who is clinically asymptomatic. After a week with the chest physiotherapy, he could achieve the lung expansion like this. So many of the time, they do not require any intervention. But if there is a fluid, the timely diagnosis is very, very important. How to prevent this complication? In my regular practice, about 80% of my cases, I choose the supracostal, more lateral approach. And even in the mild hydronephrotic cases, I can approach from middle calyx to upper pole without any difficulty. This is one scenario. And another, even at the angulation like this, we can enter from the lower calyx to the upper pole without any difficulty. And this is how we can avoid the supracostal puncture. The next, again, the case like narrow infundibulum in the upper pole, there is a stone. We advance from the lower pole to the upper part without any difficulty. If there is a stone, we just fragment them into multiple pieces, then we just flush with the irrigation pump. These stones will automatically come outside the system. So this is the endoview, which is very important. You can see the fornix of the kidney. Even there is a stone in the upper pole and the lower pole, we can easily have a maneuver like this. On table, we can decide more than 95% of the stone clearance. We can advance to upper pole. This is how we can avoid the supra 10, supra 12 or supra 11 puncture. We do not leave any stone inside the kidney after the mini PCNL. That is the beauty of mini PCNL. We can advance these scopes in different calyceal system. And these people generally do not need repeated CT scan to see the residual stone after the PCNL technique. Well, I have already mentioned about this. The only important is the when you go between 10 and 11, it should be more horizontal to avoid the visceral injury. So I'm sure regarding the fever and sepsis, Dr. Bhojraj will highlight more on that. The only thing I would like to inform about whenever we talk about the mini PCNL, people are concerned about the high pressure when you do the mini PCNL technique. This is a study done by Professor Chang, my own professor. He did a study in 14 FR, 16, 18, and double 16 percutaneous tract. He observed that these pressures are not above the 30 millimeter mercury. If the pressure, that is the threshold, if the pressure goes beyond that, there is a high chance of venous lymphatic backflow, which causes the sepsis. So the important here is the space between the sheet and the telescope is utmost important. It should not be less than 4 FR. And that is the pressure you can see, you have seen that. When the pressure, when the space between the sheet and the scope is more than 4 FR, it is completely safe and stone evacuation is much faster. Well, injury to colon can occur in 0.2 to 1% in PCNL cases, and 85% of the cases of colonic injury get managed by conservative means. I just want to share one of my case. This is a horseshoe kidney stone in 62 years male patient whom I performed mini PCNL technique. My initial puncture went more deep down. I thought this horseshoe kidney may be located more deep. Then I realized that kidney was located more superficial. Then I performed mini PCNL, stones were evacuated. Then after 48 hours, this patient got abdominal distension and vitals were deteriorated. We did the CT scan, noted the perforation, and we had to do a colostomy. See friends, this is not with the tract through and through the colon. I just want to give the message that even with the 18 gauge needle puncture, if you have noticed this, we may have to do the colostomy. So perforation and extravasation we face when we do PCNL. This is another case, just want to share. This is a young patient who had a 15 millimeter renal pelvis stone. Post-operatively uneventful, endoscopically complete stone clearance. I thought I'll do the total tubeless PCNL. Then after 24 hours, this patient developed fever and abdominal distension. Ultrasound was done. Ultrasound revealed fluid collection, then advised for the CT scan, and this is the CT scan you have seen. It's a clear-cut mini PCNL technique, uneventful procedure. Then we placed the double J stent. Next day, again repeated the IVU. There was no extravasation. So prevention must leave a drain whenever you anticipate untable or future fluid extravasation. Always reassure distal patency, adequate drainage. And these are about the incidence of perinephric hematoma after percutaneous nephrolithotomy, and injury to spleen and liver occurs in cases of splenomegaly or hepatomegaly when there is a puncture above the 11th rib, and we should use the ultrasound. And these are miscellaneous complications we may face during the PCNL or mini PCNL. Well, if we go with the miniaturized PCNL, if we do PCNL with the precise puncturing and tract dilatation, we can minimize this complication rate. Thank you very much.
Thank you, sir, for an excellent talk and listing all the complications. And we do have a lot of questions for you, and we'll take up at the end of the session.
Sure.
Can I request Dr. Bhojraj to please start his talk on septic complications of PCNL? Please share your screen, Dr. Bhojraj.
Yeah, I'm doing. Yeah. Good afternoon, I think now. What's the time now? It's still good morning, sorry. Yeah, thank you very much for inviting me for this presentation. For next couple of around 10-15 minutes, I'll be talking on surviving sepsis in neurological management of nephrolithiasis in 2020. A very warm greetings from Kathmandu, Nepal. So mainly the objectives of my presentations are, all of us know that sepsis and SIRS is part of the neurological surgery. To highlight the problem, there is changing definition of the sepsis from sepsis 2 and to sepsis 3 now by 2018. And how to prevent urosepsis and how to detect earlier, and some highlight about the surviving sepsis campaign guideline of recent one, that how much is applicable to urology, that is also a matter of debate, but some guidelines that guides us in the pathway that we can apply in urology, we'll discuss about that. All of us know that RIS and PCNL are the minimally invasive procedure of choice, but they are not immune from complications. They have some associated morbidity and mortality also. And if you see the gross global guideline, then study, then around 10.5% had fever, and sepsis in 10%, 10.2%, and mortality due to sepsis was in 2 cases. So in RIRS, in other study by Moreppan et al., they have mentioned that the SIRS is 9% and severe sepsis in 3%. And PCNL, the SIRS is higher, and sepsis also is there. Why it is so important? Because the cost of sepsis management is a very big one, because there are certain medical and legal mitigations, and there is really some financial toxicity related to the management of the urosepsis itself. So mortality associated with RIRS and PCNL, if you see that, RIRS mortality chance is lower than PCNL, of course, but case reports are there. Sepsis-related complications of RIRS and mortality. Mortality out of PCNL, that out of 1,000 PCNL now in 2024 died due to sepsis. I mean, now in recent also this data is not changing much. What is the challenge of detecting the sepsis after PCNL or RIRS? Because in PCNL, this might be complicated by hypovolemic shock as well, we should keep in mind. And septic insult on top may lead to the refractory shock. And post-RIRS shock is septic one unless proved otherwise. Until and unless there is bad pharyngeal rupture and bleeding, then we should always think of post-RIRS shock is septic one unless proved otherwise. What are the challenges of detecting the septic after RIRS? Again, is that we work on suspicion only. Urine and blood culture takes 48 hours to be available. Golden hours we might be losing. Few markers are there. Arterial blood gas analysis might reveal lactate increment, metabolic acidosis, or respiratory alkalosis. Procalcitonin is really a good marker, but it is not available everywhere. Remember that, are there any markers of covert shock clinically to detect? Yes, they are there. Oliguria, decreased urine output, metabolic acidosis, and respiratory alkalosis. These are the early markers of the covert shock. This we should always keep in mind. And here I would like to highlight that which post-PCNL or post-RIRS fever is significant. Remember that fever associated with hyperventilation, tachypnea, okay, and respiratory alkalosis. They are more dangerous one, because if you see the Campbell-Walsh serology also, hyperventilation with respiratory alkalosis is the earliest clinical marker of sepsis. Risk factors for urosepsis in endourology, all of us know there are certain perioperative factors, intraoperative factors, and so many factors are there. All of us know, but out of that, I would like to highlight is that histobiotic stones, positive urine culture, prolonged operative time, high intrapelvic pressure, especially in RIRS, and long operative time. These are the main risk factors. So can we predict sepsis related to PCNL or RIRS so that we can act on prevention of urosepsis, early detection of urosepsis, prompt resuscitation and management? Yes, literature mentions about that. Perioperative C-reactive protein, quantitative one, high sensitivity CRP or HSCRP albumin ratio, or neutrophil NLR ratio. They can guide that this cohort of patients might go to intraoperative SIRS or sepsis or postoperatively. Intraoperative pelvic and urine stone culture, yes, especially in matrix stone and staghorn stone, we routinely send many of the patients which see these stones, matrix stone especially, to the culture, but for coming the report, it takes time. Little bit I would like to highlight about there is changing definition of sepsis. Sepsis in 2016, now the definition is changed. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, clinical definition, previously sepsis was based on the SIRS. SIRS plus infection suspected or proved is sepsis. But now there is suspected or documented infection and acute increase of equal or more than 2 sequential organ failure assessment points. This defines sepsis. Now, this is big departure in the literature that the sepsis that we have defined in 2016 or 2000 and now 2020 is different. Already I have highlighted that in old category, the sepsis suspected infection plus equal or more than 2 SIRS criteria. But new definition is that suspected infection plus equal or more than 2 SOFA score. This we should keep in mind. Now, because in literature, to make it more unanimous one, we should follow this changing definition. And previously the term was there severe sepsis. Now this category has been removed. And septic shock, all of us know that previously persistent hypotension below 90 millimeter of mercury they have gained. But here to define septic shock in 2020 now, sepsis plus persistent hypotension requiring vasopressors to maintain MAP more than 65 millimeter of mercury. Along with that, lactate level equal or more than 2 millimole, both after adequate fluid resuscitation. This definition is near one. Now, quick SOFA for bedside screening tool for sepsis is now well established. Keep in mind that this quick SOFA scoring at the beginning was for prediction of the mortality associated with sepsis. But now it has been used for screening for sepsis as well. But it has, what is the limitation with this is that it has very high specificity but low sensitivity. So for screening still SIRS can be used, but to define the sepsis criteria, it is not possible to use the SIRS now. In quick SOFA, 3 parts are there: hypotension, systolic BP less than 100 they have kept, not 90, altered mental status, and tachypnea more than 22 per minute. Because in quick SOFA, that is hat, but I always mention that this is red hat, this is dangerous hat. Organ dysfunction score, I don't want to go in detail because all the critical care specialists and intensivists, they know, and most of the surgeons we have trained about sequential organ failure assessment, a certain aspect, they know the respiratory rate, coagulation profile, liver function, cardiovascular status, CNS, renal function, these 6-7 parameters are there. And we have the calculator easily available, apps are available. We can use that, what is the SOFA score of that patient, particular patient. Now, how to prevent urosepsis? Few salient points I would like to highlight. These are very basic things. Operate only in patients with sterile urine. If it is unsterile, please don't venture. Keep proper antibiotic, culture guided, proper duration, and go ahead. Always try to use reasonably place a ureteral access sheath for RIRS. In PCNL, you find the pus, frank pus, then put nephrostomy tube and come out. That is not the failure. That is taking a safe pathway for easy landing in the future. Always irrigate with caution, checking the continuous fluid outflow, both in mini PCNL and RIRS, I am mentioning this thing because in mini PCNR, if there is some other cross puncture or cross dilatation or pelvic rupture or something is happening, if fluid is not coming out, we should keep in mind that something is going wrong. Or in RIRS also, if the fluid is not coming out, keep in mind that the intrapelvic pressure is going to rise tremendously. Do not exceed operative time 2 hours, 1 hour for the children. This applies for both PCNL and RIRS. Carefully monitor patients in the early postoperative period, because this is the most important thing. If postoperative fever is there, quickly check the lactate procalcitonin levels. Remember that 90% of the septic complications occur within 6 to 12 hours, and we have to start antibiotics in war footing because 90% of septic complications occur within 6 to 12 hours. I am not denying that sepsis doesn't happen later on, but this is the most critical perioperative period. So how to detect early detection of the urosepsis, patient with suspected infection? You can screen with quick SOFA and then monitor clinical condition, reevaluate possible sepsis if clinically indicated. Assess for, if quick SOFA is positive, then we have to go for assessment of the organ dysfunction. If SOFA score is equal or more than 2, then that is sepsis. Despite adequate fluid resuscitation, vasopressors is required to maintain the more than 65 millimeter of mercury of the MAP, or serum lactate level is rising more than 2 millimole per liter. This is a marker of the tissue hypoperfusion, then that is septic shock. So how to manage urosepsis? The key components are measure the lactate level, obtain the blood and urine culture in time, IV fluids, IV antibiotics, vasopressor, source control, and monitoring in eye dependence unit and ICU, and early goal-directed therapy. Now, Surviving Sepsis campaign has given 1 hour bundle for all of these except IV fluids. Remember that IV fluids, we have to be very, very judicious because we should see the lots of things about IV fluid management. But the main message is that you cannot wait for 3 hours, 6 hours later that send this blood count, then we'll decide this CBC, RFT, then I'll come, and then attending the patient late might lead to the further complication, and then we might lose the patient. So again, that I would like to highlight that lactate level, we have to measure ABG or lactate level, whatever it is. If more than 2 millimole, then we have to remeasure after 6 hours after adequate resuscitation. We should obtain the blood and urine culture prior to administration of the antibiotics. Antibiotics, usually we choose the broad spectrum one based on the culture sensitivity pattern of that institute or hospital, but still there are certain fallacies in 2020 because there are multi-drug resistant organisms with carbapenem resistance group is coming now. IV fluids begin rapid administration of 30 ml per kg. Which fluid? Now there is no doubt you should not use eta starch or pentastarch. Crystalloids are preferable. Ringer lactate, normal saline, whatever it is, ringer lactate is preferred one, or some other balanced salt solution is okay. This fluid resuscitation should be guided by urine output. Along with that, you should auscultate the chest and everything. 30 ml per kg is the maximum permissive dose that we can give over 3 hours. It's not that we have to infuse that much over 3 hours. No, you have to individualize that. This is not blanket therapy. Otherwise, some patients might go to pulmonary edema and then the situation might worsen. This always we should keep in mind. Vasopressors, yes, we have to apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain the MAP more than 65 millimeter of mercury. And vasopressor, naturally, the drug of choice is not adrenaline. Dopamine does not have a role now by this time. Previously, we used to talk that renoprotective drugs, so many issues. Now, that is clear that vasopressor of choice for septic shock is noradrenaline. If that's not support, then we can add the vasopressin or some inotropes. Inotropes, you can use the dobutamine if and when required. So the bundle element already highlighted that the 5 elements, this I don't want to go in detail, but again, coming to the, what is the proof of using this Surviving Sepsis campaign bundle, 1 hour bundle, whatever is there, still evidence is poorer, but still we need some more research, especially related to the genitourinary system on this aspect, because this was originally developed by the intensivist or ICU care specialist. We have to work with them also how to manage, how this guideline is more and more suitable for urology patients. Still the evidence is poorer. So coming to the microbiological aspects there, then blood culture or urine culture, at least 2 shades they mention. And urine, how to collect? If there is indwelling catheter, if it is less than 2 weeks, then we can collect the specimen by puncturing the Foley's catheter. If more than 2 weeks, then we have to replace the catheter and new urinary sample we have to send. Antibiotic empirically, yes, if there is a multi-drug resistant organism suspected, then we have to go for combination therapy. If not, then we can use third or fourth generation cephalosporin, piperacillin or BLI, combination with BLI, and carbapenem, meropenem, or imipenem, whatever is there, we can choose that. But if combination regime is needed, if you think of multi-drug resistant organism, remember that while choosing the antibiotic, you should be very, very judicious. Now we have the common resistant pathogens. Mnemonic is that escape organisms, that is Enterococcus, Staphylococcus, Clostridium, Acinetobacter, Pseudomonas, Enterobacteria. These highlighted one, Acinetobacter, Enterobacteriaceae, and Pseudomonas, these bugs are really torturing urology practitioners now. The reason is that we have lots of resistant, like ESBL, if it's prevalent, then carbapenem is drug of choice. Then carbapenem resistant enterobacterial, if it is there, then ceftazidime we might need to choose. Then polymyxin based regimes also we might require, we should always keep in mind, but better to tailor this therapy based on the culture and sensitivity report. Like Delhi superbug, that is MBL positive, metallo-beta-lactamase positive, then aztreonam is drug of choice. This principle and what next, that you should keep in mind, that I'm not telling that we have to start this. No, first line is again carbapenem, BLBLI, that group might suffice. But what next, as a urologist, as a practitioner, we should have this idea also. For CRAB, that is carbapenem resistant Acinetobacter Bowmani complex, then polymyxins group are now, and ceftazidime, if it's available in America, not in Nepal. And then this plethora of drugs are there, judiciously how to use. You consult the microbiologist, consult the infectious medicine specialist, and we have to work in conjunction with the intensivist as well. Newer antibiotics with activity against carbapenem, now they are coming in the market, like aztreonam avibactam, cefiderocol, imipenem relibactam, and meropenem beveribactam. These are the antibiotics that they are coming in the international market. In India also, in certain centers, the supply and demand. In Nepal, it is not available. But about this, principally this knowledge also we should have. What next beyond carbapenem resistant, we should be ready in our minds. Source control in urosepsis is very important. Source localization, I have highlighted that microbiological aspect, and imaging, ultrasound and CT scan. Please have a very, very low threshold of using ultrasound and CT scan post-procedure if you think that certain sepsis or other complication related things are happening in patients, those who undergo endourological intervention. And regarding source control, after localization, we have to go for the source control, catheter removal and exchange, stent removal, decompression of the infected hydronephrosis, internal or external drainage, perinephric collection or pictal drainage, and bowel injury, pleural injury, that debridement, diversion or chest tube insertion, like empyema or whatever they are, or urinothorax, urinoma, all those things you should be very, very well equipped for debridement and diversion always. Only once you think that you can act upon. Otherwise, we might lose the golden window of detecting this problem and correcting in time. In summary, to surviving sepsis in endourology, now to suspect the sepsis, along with SIRS, we have now quick SOFA in 2020, Q-SOFA. Sepsis criteria has changed. It is no more based on SIRS now. It is sepsis criteria plus SOFA score equal or more than 2. Early goal-directed therapy, 1 hour bundle and continuous monitoring. Empirical antibiotic therapy. Anyway, we need to start with either combination therapy or isolated one. And as a urologist, we have a very, very great role for timely source localization and source control, taking help of microbiologist, radiologist, and our own colleagues and procedure specialists. By this, we can make the patient surviving of the sepsis in 2020. Thank you very much.
Thank you, Dr. Bhojraj. That was an excellent talk and summarization of how to go about managing of septic complications of endourology. I would like to move on and invite Dr. Bipendra Rai, and Dr. Rai will be talking to us about management of post-PCNL bleeding. Welcome, Dr. Rai. Dr. Bhojraj, please stay with us.
Thank you.
Can you share your screen, Dr. Bipendra? Yeah, we can hear.
Okay, you hearing my voice?
Yes.
Okay, so my slides are there.
Yeah, we can see your slides. You'll have
Okay,
to.
so we'll go with the presentations. Okay, so I'm on.
Yes, you're on.
So I thank you, the Alto group, which has really revolutionized the learning in the, not only in COVID year, but probably is a future of learning now with so many people associated with Ulto. And I thank Ulto for this opportunity and organizing. So, and I think I also should thank Dr. Anil for organizing all these topics. And so I am my guide, Professor Prem Gyawali, here when I was doing an MCs. I also thank him for what I am. And I also want to thank the Institute because the topic I'm presenting, a lot of the data are from my prior, from my original parent institute because I don't have embolization in my center. So I do refer these patients to my parent institute for management. So these are the overview of the topics that I'm going to cover. PCNA has been a standard of treatment for stone size more than 2 centimeters, but with upcoming minimally invasive techniques like RIRS, the indications has remained the same despite that. But because of the complications associated with PCNL, which is much higher, people have tried to extend the indications for RIRS to stone sizes larger than 4 centimeters. It's mainly because of the complications like bleeding. And reported series as high as 1 out of 4 patients have significant clinical bleeding, which requires some intervention. However, the good thing, the body heals, and 90% of these bleedings tend to be recover on their own, and only around 10% of the bleeding, roughly includes around 1% require angioembolization. And in 2017, there was a paper published from my parent institute in which the embolization rate recorded was 1.9%. It included nearly around 120 patients. And those bleedings usually occurred in patients with high stone nephrometry scores, like a stone score was high and even the guy's stone score was high. And the reported mortality rate due to bleeding around the world is around 4%. So going to the risk factors for a requirement of angioembolization. This is not for bleeding, for requirement for embolization. There was a meta-analysis published in 2020, and they studied the various factors I think they studied around 10,000 patients in the population. 7 studies were included overall, and they found 4 factors that predicted the patients for requirement for angioembolization. UTI was one of the factors. Diabetes mellitus with all the endothelial dysfunctions. These patients tended to have higher chances of requiring angioembolizations. And then patients who had either multiple tracts inserted or stagnant stones requiring manipulations and multiple tracts. These were the patients that were identified as risk factors for requirement of angioembolization. So when you counsel these patients, maybe that you have to tell them that their chances might be high that you might require angioembolization if and when bleeding occurs. So why does PCNL bleed? If you see the picture on the right-hand side of the screen, you don't need to be a rocket scientist to guess the amount of blood supply to the kidneys. The 20% of the blood supply of the total cardiac output goes to the kidneys, and each gram of renal parenchyma there's around 10 ml of blood at each time in the kidney. So when you puncture the kidney, the chances of bleeding is high. Fortunately, most of the bleeding are benign and they tend to resolve. So bleeding can either occur as a result of venous injury. Bleeding usually occurs as they appear as dark blood, and they tend to all of them tend to recover with conservative management. We have seen, I think, 3 weeks back when S.K. Pal sir presented his topic on PCNL. He did a venoscopy during a percutaneous procedure, and he completed the stone. However, this patient resolved with conservative management. So venous injury is really forgiving. Most of them don't require any intervention except conservative care. What worries us is the arterial injury because they are prone to form pseudoaneurysms and AV fissures. Why is it so that they form? Because of the high pressure system. And studies have shown that most of the injuries which are significant, then these injuries are either to the segmental or the lobar vessels. Most of the interlobar vessels, though they may bleed intraoperatively, they don't tend to produce prolonged delayed bleeds, and they don't tend to produce significant cardiovascular dysfunction. And when the injuries are to these segmental vessels or interlobar vessels, then most of these patients don't recover on their own, and intervention is required. So how do they present? Basically, the presentation can be either in the early acute phase, that is a continuation of the bleed, which was intraoperative bleed, which persisted in the first post-op days. Majority of them recover, and some of them continue to bleed, and we have to do it. And most worrisome thing about PCN, which none of the urologists want to treat, but must know how to treat this, is delayed hemorrhages, and they are really troublesome. And most of the papers, articles that they publish, the presentation is majority of them present within 2 weeks. Median time is a 5 to 10 days is the most of the commonly reported time, but most of them present are 6. But reports of presentation for delayed being as long as 3 months has been recorded. So there's no time period beyond certain time where bleeding can stop. But this is bleeding to present beyond 2 weeks is uncommon and rare. So, and they can present with pain. Pain can be as a result of either clot colics or can be result of retention and acute distension of the bladder. Then hematuria can be they can be intermittent gross hematuria or can be continuous. Most of the venous bleedings they tend to be continuous, and in the early phase of the post-op period, and arterial bleeding they tend to be either acute and massive in the early post-op period, or they present intermittently in the delayed period. And most of us have experienced clot retention with profuse bleeding and has performed clot evacuations, and then patient can sometimes present with shock. So directly going to the management. So what is the aim of the management when these patients do present with the bleeding? So for and foremost thing that we need to do is stabilize these patients in terms of adequate intravascular fluid volumes, in terms of replacing the blood loss. And then second thing that we need to do is relieve the symptoms, that we relieve them of pain. Most of them can present have retention. You need to irrigate these patients with widebore three-way cannula, three-way Foley's catheter, and sometimes more we need to even do clot evacuations, putting them in the theater. And you have to relieve them of the anxiety. The patients are very anxious when they present because they have gone to their homes feeling that everything has gone out, and suddenly they have massive amount of blood, they are passing clots, and the patients are really panicked. So you need to tell them that they need not worry, that there are treatments available, and you are going to get fine. And the most important thing that we need to do is investigate this patient. I think most of us will be lacking in this in the early phase of the period. So by the end of this presentation, I hope the investigation part will be most early and prompt with associated with all the urologists who do PCD. So whom should we investigate? This is very important slide, I think, for us. Number one point is any significant bleeds which occurs more than 24 hours after the bleeding has stopped. That means the bleeding patient has recovered. You send this patient home. If this patient comes with significant bleed after 24 hours, beyond 24 hours, then these patients must be investigated. And then in patient who like immediate post-op periods, most of these bleeds recover within 48 to 72 hours. But if there's a persistent requirement of blood and products, or there's a persistent continuous fall in hemoglobin beyond 48 to 72 hours, then these patients must be investigated further. So it's always better to be safe than sorry. So because it can significantly reduce the morbidity of the patients. So what are the diagnostic tools? Ultrasound Doppler, well, in our institute, we are not using an ultrasound Doppler for diagnosis of this bleeding because few other things is most of these patient late, and ultrasound Doppler is very much operator dependent. It has to be done diligently, and in the emergency setup with all those patients who are coming around. So we usually don't do a Doppler ultrasound. So it's not a routine practice to do Doppler in these patients in my parent institute. And so most of these patients, if they come to our institute, they were subjected to CT angiogram with reconstruction. The sensitivity of this CT angiograms is reported to be around 90%. So you have to see that still 10% of this can be missed, but most of them report that bleedings which are missed in angiograms, even in CT angiogram, they tend to recover on their own and are not significant. But there has been case reports where MDCT has missed a bleeding point, and subsequent conventional angiogram has diagnosed the disease. So if you consider this bleeding significant, it's a suspect an injury, then it's better you do the conventional angiogram there and then subsequently. Or conventional angiogram has a very high sensitivity rate for detecting all these aneurysms uh, and diagnosing aneurysms. And these are important because you can also intervene in conjunction with the diagnosis, do embolization at the same setting. So going directly into the management point of view, basically three-prong management is there. Most of us have gone through this conservative phase in the immediate post-op period where we observe the patients. And nephrostomy tube was common when we started doing PCNLs in 2010, 2012. Now, most of them PCNLs are tubeless procedures. So at that time, when nephrostomies were there, then we were told to clamp the nephrostomy for at least 2 to 4 hours post-surgery and allow the blood to clot so it decreases the bleeding. The reported rates of nephrostomy clamping has been from 2 hours to 48 hours in various studies. So there is no hard and fast rule how long to clamp. It's all your consumption. Now without nephrostomy in most of our PCNLs, so this option has been absent in our practice. So we observe them for 48 hours. And next is the use of antifibrinolytics like tranexamic acid, which has been shown in various studies to reduce the blood transfusion rate and has been shown even in trauma settings to decrease the requirement for blood products. So this can be used. However, there is not a lot of data to support using this in post-PCNL bleed, but they have been used to prevent blood bleeding complications in PCNL. And supportive care, blood products, IV fluids, and pain management is all there. So when a conservative management fails, when there are indications, like I said already, transarterial embolization is the management of choice. Most patients coming with delays hemorrhage require antiembolizations. Uh, Pseudoaneurysms have been reported to heal spontaneously, but it's a rarity. It's more of a rarity than a norm. So unless until unless proven otherwise, this data support says that aneurysms, once they form, they don't heal on their own, but they require angioembolization on the long run. So these should be treated. And the reported rates of nephrectomy is around 0.2% in some of the literatures. Our center, I don't think I have recall a memory of doing a nephrectomy for angioembolization for bleeding post PCL. But most of these nephrectomies reported are from centers either where the angioembolization was not possible or patient was too unstable to undergo an angioembolization. So in a center with a good angioembolization procedure available, I think nephrectomy rates are near to zero. So going into the embolization, this is a data published from TUTH in 2020. I thank Dr. Dinesh, who is an expert in embolization, who published this article from his experience from TUTH. And the embolization success rate in our center was 93.3%. So reported success rate ranges from 85 to 95.5%. So around 5 to 7% do require re-embolization. Pseudoaneurysms were the most common cause of bleeding post-piscinal in this study, and there was a significant portion of the AV fistulas in the center. So AV fistulas have been, especially in biopsy setting, has been shown to recover on their own. So probably that's the reason why AV fistulas are much less. And if you saw the trend in the graph we saw, there's increasing trend of embolization. This graph is fortunately does not only include embolizations from our center, from the center in TUTH. It's also because TUTH is the center which is doing embolization regularly. Most of the embolizations, surgeries requiring embolization are being referred to the center. So that's why the data are large in the number as compared. So the increase in embolization just signifies that the number of post-PCL procedures are increasing, and there's widespread availability of PCL procedure. That's why there is an increase subsequently. So next thing, how do you manage post embolization? So this is more of our institutional protocol that in my former institute, what we used to do with all these patients. And I think this is important because not a lot of the urologists are probably managing this embolization and post embolization period. So the institutional protocol was get a good rest till the hematuria subsides. Usually they subside within 24 hours if the embolization is successful. At most it may take 48 hours, but 24 hours, by 24 hours most of them have clear urine. Then in around 48 hours the compression bandages are removed with associated with the Foley's also. And in between time, we watch for whether there's gross hematuria or not. We monitor the vitals, send hematocrit around 12 hourly. And once you remove the Foley's, if patient does not have gross hematuria for more than 24 hours after the Foley's removal, then we tell the patient that they can be discharged. But since most of the patients are being referred from peripheries, they tend to overstay our advice for a few more days. So they usually tend to stay for additional 2 to 3 days just to be sure, because they have had a horrendous experience of bleeding. So when ultimately the patient gets discharged, the protocol is to tell them to take a good rest for at least 2 weeks post discharge, and no exertional activities, that they may do non-exertional activities for the 2 weeks. Then we follow this patient. If there's no hematuria, then they can continue the regular activities, and we ask them to follow up in our OPD at around 6 weeks time, or SOS if rebleeding occurs. During this period, the most investigation that we do is ultrasound. We ask for probably ask for a Doppler at the time, and they can see abnormal changes. They can see abnormal flows and pattern in a Doppler, and they can see any untoward complications that may have occurred in between this time. And urine routine RE we usually do to see whether the hematuria has resolved or not. And creatinine is not required, but the patients are so worried that the kidneys are functioning or not. So we, as a part of a routine investigation, we did this creatinine just to give the patient a good feeling that his kidneys are functioning well. Then following that, the next follow-up is usually done around 3 months, where we just repeat a urine routine to see if there's any persistent bleeds. After that, most of the time, we don't keep this patient in follow-up for bleeding, but for stone disease, they may be kept on follow-up. And full activities are allowed following 3 months. There's no restriction in activity after 3 months. So there are complications associated with any procedures, and embolization is not any exempt of it. Failure is around 7%, reported 7% in our institute, but reported rate around the world was 5 to 20%. And surgeries has not been done in our institute, but the reported rate, as I told before, is around 0.2%. Post-embolism syndromes is not common in PCNL because of the superselective embolism and very minimal parenchymal loss. This is more common with embolizations associated with large renal tumors, where they are even in massive saturated kidneys, where they do loss of parenchyma is large. So we have not seen this post-embolism syndrome during this for PCNL. Coil migration has been reported in literature with catastrophic consequences not seen in our center. And renal impairment, because of the supercellular nature of the embolization, is very rare. Contrast-induced injuries are a possibility, but one thing you have to be sure is these patients have to be adequately resuscitated, blood pressure maintained. So this probably reduce the contrast-induced injury as well as renal impairment. So to conclude this short presentation, so before concluding this short presentation, I want to show a video clip just to show this. So this is one of the case where embolization was done, and there.
We can't see the video, Dr. Bipendra.
Okay, you can't see the video.
Yeah, we can't see the video. You have to minimize the PowerPoint.
Okay, sorry. So, can you see the video?
No. In the share screen button, you'll have to select the player.
Okay, is that fine? Are you seeing my screen?
You have to stop sharing your PowerPoint and share the video window.
So I've stopped this.
PowerPoint.
Okay, it's share screen. Yeah. Okay. So I think this is what share. So are you seeing it now?
Yeah.
So this is one of the patients where angiogram was done, conventional angiogram following this. You see the anterior and posterior vessel, and subsequently, if you go and see, then we see a blush of contrast in the one of the interlobar arteries, which persistently increases, and you can see even a venous runoff in this case. So subsequently, this patient then underwent embolization. Are you seeing my video now? Okay.
We saw the video, the first one, but now we are not seeing it.
Are you seeing this?
No.
No.
You have to share the screen again.
Okay. Sorry for this.
And I would also request you to speed up.
Yeah. Now after this, are you seeing this?
Yeah.
Yes.
Yeah.
So this is just the post-embolization period, and you see the coil. Then embolization has done. Then we don't see any blush of contrast after embolization. See, this is coiling has been done, and we saw aneurysm here. Now it's gone. Okay. So now I'll just stop share. So
Dr. Bipin, you come back to your slides.
Yes, sir. I'll just now this. So to finally conclude, do you see my slide?
Yes, we can see.
Okay.
Yeah.
So this is my final slide. So the take-home message would be that delayed post-patient needs have created havoc to our practice. But the most important message that I want to share is you need to investigate this patient promptly. Most of the patients who has been referred to our centers have been that they have undergone multiple blood transfusions, they have had multiple recurrent bleeds, and have undertaken multiple clot evacuation prior to being referred. So I think once you have an indication for bleeding, you investigate this case, and then refer them promptly to centers where renal artery embolizations are there. And I think it's a very good task to make friends with the radiologist who does embolizations. Make good friendship, so you can call him at any time at the night time, anywhere you want, and he will take care of your patients. And TA, because TA is a safe and effective and expert hands. So thank you and stay safe.
Thank you, Dr. Bipendra. That was an excellent talk. So we'll move on without spending more time. We'll move on to the questions that have been asked. I will just share the presentation. So again, I would like to thank everyone for excellent presentations. All the talks were really very good. Speaks a lot about the quality of work going on in Nepal and the expertise that you have there and the depth of knowledge of all the urologists. Again, thank you. And we'll move on to questions, and we'll take up the questions basically to individual presenters. So these are first set of questions are to Dr. Prem, sir. Sir, are you there?
Yeah, I'm here.
Yes, sir. So Dr. Nitesh has the first question for you, so I would request him to ask himself.
Sir, I just wanted to know whether you do COVID-19 RT-PCR in all cases as a pre-op workup, suppose if you are doing an elective case as well?
Dr. Nitesh actually saying not at all.
Okay.
In whole country, we are unable to perform the reverse transcriptase PCR test in the country, and we are not able to. In my hospital itself, there is no machine for the RT-PCR test, so we are not doing this.
Sure.
And I apologize because my internet is somehow disturbing us. I would be like to ensure if it would be given to me first, because my Wi-Fi can go anytime. I'm afraid of that.
So the first set of questions are for you only, and right now your internet is working perfectly. Dr. Anil, you want to add something to the availability of PCR tests?
Yes. One of the centers, there are a few centers in Kathmandu where we do RT-PCR. And in my center, we do RT-PCR, and we don't do elective cases now because I don't think, not only in my center, I don't think any center is doing elective PCR in government setup. I don't know about private setup. So we have done cases, semi-urgent cases last week in my center with RT-PCR. Yes, to answer Nitesh's question.
How early are you getting the reports in your center?
If we send by noon, by before 11 or 12 at the day, then we'll get it by 3 p.m. in my center.
Oh.
3 to 4.
Actually, that is the antibody test. That is not the RT-PCR.
No, it's
RT-PCR.
RT-PCR.
RT-PCR, it takes 24 hours minimum.
No, sir. If you
4 hours.
If you send it from your center, then our center dispatch you the report within 24 hours. But in my center, we get it within 4 hours.
Oh, is it? Then good. Congratulations.
If a private practitioner wants to get a preoperative RT-PCR for this patient, can they send the patient to your center, Dr. Anil?
It's really difficult. Actually, the kit for RT-PCR in our center is very limited, and there are strict criteria for doing RT-PCR that has been set up by our government. So it's not actually possible.
Right. So Dr. Narayan Ushal wants to ask you, Dr. Prem, sir, that if there is a patient with obstruction, ureteric obstruction, and has fever, is it mandatory to do a PCR before taking him to OT?
This case question is for me?
Yes, sir. Yes, sir.
No, actually, RT-PCR is recommended in each and every cases. It is recommended. But in case of emergency, in my presentation, I told this emergency depends upon your capacity and your demand. If you can do it, just Dr. Anil said, there are some limited criteria which patients can undergo those type of the test. Yes, not in case of emergency, you would not have time. In most of the institutions, the RT-PCR tests are done within 24 to 48 hours, then you do not get. In your case, which you told here, you will not have time to wait for 24 to 48 hours. You should take precaution yourself. You should protect your health personnel, your anesthesiologist and your nurses, and you should take care. If it is possible, if it is there, yes, it's fine and good. If it is not there, you cannot delay the emergency surgery.
Yes, we should treat every patient as positive and go.
Yes, that is true.
So there's a question from Dr. Nitesh Jankarki. He asks, is it compulsory to have a positive pressure OT for COVID-19 patient? I think what he means is a negative pressure.
Yeah, question is wrong here. It is not positive, it is negative pressure. It is recommended. It is recommended, but not absolute.
And what are the chances of transmission if we operate in regular OT with PPE? Are there any references regarding this?
No, what else you need? You need the proper use of the PPE. You should protect your health care personnel. You should protect your machines and decontaminate after the use. Yes, you can do it. You can protect. Definitely, there may not be the 100% protection. It is near to 100% if you use the PPE properly.
So the next set of questions is to Dr. Anil. I would request Dr. Please. Dr. Nitesh, are you there? Okay, I'll go ahead. So Dr. S.K. Paul sir wants to ask you, what is the difference in results and complications of nicely conducted ESWL on a good machine versus RIRS for a 700 Hounsfield unit 2 centimeter stone? Which technique would you prefer on yourself?
Yeah, firstly, I would like to say that I don't want any procedure on myself. So I think I have replied SK Pal sir in Facebook, but I want to tell again that there are very striking differences between ESWL and RIRS when it comes to 2 centimeter stone in lower pole. We have enough evidence on the basis of enough systematic review and meta-analysis that when the stone size is around 1 to 2 centimeter in lower pole, the success rate of ESWL goes down, and the success rate with PCNL and RIRS is significantly high. The need of auxiliary procedure is high with ESWL. So even if the Hounsfield unit is 700 with 2 centimeter stone, the number of dust and fragments, number of fragments and dust produced by after ESWL is high, tremendous, you know. So the passage of those fragments from the lower pole will be, not very adequate because ESWL is what I consider ESWL is a passive procedure, whereas in endourology, in mini PCNL or RIRS, it is active procedure. You don't have to depend on technician of who is doing ESWL. You don't have to depend on which ESWL machine do you have, because you can actively retrieve, fragment, relocate, and take out the stone. So obviously in 2 centimeter stone, no doubt, either RIRS or PCNL will be the best.
Question is something that was there on my mind. I wanted to ask you that are there any tricks that you would recommend to manage a stone completely blocking the lower pole infundibulum? You know, there are those little longer, narrower infundibulums and stone is completely blocking them. So would you give any tips for that? Yes.
See, whenever we talk about success rate in any stone surgery, not only lower pole, first thing is stone size. So I'd like to know the stone size. Even if it is completely blocking the infundibulum in the lower pole, if it is not very big, then it's not a big procedure. It's not a difficult procedure. If it is a big procedure, then yes, Tanuj, it can pose some difficulties managing that stone. So what I will do is, if the IPA is not very narrow, then you just start fragmenting or start dusting the stone, open the infundibulum from one side. Then if the stone is not very big, not very hard, then you can finish it in the lower pole and take out the dust at the end by flushing out. If the stone is big enough, then you have to fragment it in some big pieces, relocate it, then finish the procedure in upper or middle pole, wherever you are comfortable.
Thank you for that. Dr. Nitesh, you want to take the next question?
Just
The one that Prem
wanted
asked.
to know, so what is your recommendation when there is a stone of more than 1 centimeter and we are not able to relocate the stone? So what do you do in those? Can you share your tips for that?
Yes, it happens quite often when we treat lower pole stones. If the stone is more than 1 centimeter, then many a times it is not possible to relocate the stone in toto at one time, right? So in that case, what we have to do is we have to fragment that stone in situ in lower pole. And please keep in mind that the laser setting should be of low energy. Even if you are fragmenting, don't increase the low laser setting more than 1 joule, and keep the frequency low so that total energy becomes low. Use long pulse, fragment the stone in 3 or 4 pieces, then relocate them separately in the favorable calyx and finish the job.
So same, just continuing with the same question. Suppose there is a stone of more than 1 centimeter and the infundibular angle is also very acute. Do you explain your patient about need of mini PCNL, or still you are more comfortable in doing RIRS?
See, more than 1 centimeter is, I would say, it's a vague size. You have to be specific. It can be 3 centimeter.
Just 1.5 centimeter or 1.3 centimeter stone in lower calyx. The angle is very acute, infundibular angle. You are not able to relocate. Do you explain your patient about need of mini PCNL, or you never explain the patient the need of mini PCNL?
Definitely, we have to explain not only about the size. When we talk about steep or narrow IPA, then it doesn't matter what is the size of the stone. Sometimes even for 8 mm stone, if the IPA is very narrow, then we had cases when we could see the tip of the stone. I mean, we could not lace it completely. We could see the tip of some part of the stone in lower pole, but we could not finish this job when the stone was even less than 1 centimeter. So in these cases, the size doesn't matter much. What matters is IPA. Definitely, we should counsel the patient pre-operatively about need of alternative or mini PCNL in those cases.
Thank you.
Dr. Nitesh, can I add something here?
Yes, sir, please, sir.
Because I'm also doing the regularly RIRS. The main thing failure in the RIRS is the loss of deflection. If there is acute angle anywhere, the deflection is reduced, then the failure chance is high. In your cases, if the stone is, it may be even lesser than the 1 centimeter in size, but if the quite acute angle is there, your deflection of your flexible ureteroscope is not sufficient, then again you can fail. So the main thing in the RIRS success and failure comes with the deflection. Is this good deflection at the site of the stone or not?
So that's the reason I raised this point. Actually, I wanted the viewer that in case if you're doing lower pole or any other pole RIRS, we should also consult the patient regarding need of alternative procedure like mini PCNL and other stuff, whatever the size of the stone is. That's the reason I raised this question.
Yes, sir, definitely. Always you should give the alternate option which may occur, and you may need the another procedure.
So, Dr. Rani, I want to ask you one more question.
Yes, please.
Will Hounsfield unit ever change your management in lower pole stones more than around 1 to 2 centimeters size? If you have indications like in this Hounsfield unit, even the stone is in between 10 to 15 mm, you won't do RIS, you probably go to PCN. Is there a set value that you would probably not prefer RIS in those cases?
See, I think that's a very good question. That thing always was in my mind. HU was never taken seriously in guidelines and in discussions, and I personally think that HU can really matter when we do RIRS. Though we use Holm-Emiag laser, which is, gold standard, and it is effective in all types of stone, but hard stone, when the HU is higher, then the procedure becomes lengthier. There's a chance that you might, you will have to use a higher power laser setting, then your breakage of laser fiber and the total lasing time and operation times goes up. But to answer your question, if the stone size is around 15 mm in lower pole, even if hardest stone, calcium oxalate monohydrate, I think I'll go for RIRS. It will take a little longer time, but we can finish it pretty well.
And you can break anything with laser, so
Yes.
similarity.
The only thing is you'll need a longer operation time with a harder stone.
So thank you, Dr. Anil. We'll move on to the next.
Can I add one point that I was asked by one of the viewer in Facebook. There was a question, it's not about a lower pole. There was a question how to negotiate the kink of upper pole, upper ureter. I think Tanuj was there with me in my theater. We had a live operative session. It was actually done by Professor Traxler, and it was really difficult case. I think lots of friends there, they were there, and he tried everything. He tried everything, and lastly, he's a master. Then he could manage. So there are various types of kinks. If the kinks are not very acute, then we can just use some force of irrigation. Then we can negotiate with hydrophilic guide wire. If the kinks are very acute, then we might have to use different guide wires like stiff guide wire, stiff hydrophilic guide wire, or sometimes Jebra guide wire to backload our scope and negotiate to the PCS. And it might not be easy, and it may not be successful in all the cases.
I can never forget that case.
Yes.
It was a really bad thing. Yeah. So we'll move on to the next set of questions to
Thank you.
Dr.
Thank
Robin. Dr. Robin, are you?
Yeah, I'm here.
What are your tips of treating isthmus stone when even the flexi nephroscope at times is difficult to reach there?
Thank you, Dr. Nitesh. I think the stars have been lucky for us. We've not had any difficult stones where it was difficult to get into the isthmus, but there may be chances where it's very difficult to get into the isthmus. But one thing I wanted to highlight in my talk was, if you go through the upper calyx, the path is usually straight. So we can go anywhere in the dorsal kidney, number one. Number two, we may have to make another puncture. That is, we may have to go through the middle calyx also. Going through the lower calyx or direct hitting the isthmus is not recommended, because usually the vascular malformations are on the lower side. That is one thing. Another thing is, isthmus, it overlies the vertebral column. So you cannot go directly, it's very difficult to go directly into the isthmus. So another approach is flexible nephroscopy. But you've said flexible it may be difficult at times to go through the flexible nephroscope also. At that time, we can recommend, if the stone is very big, we may recommend for a laparoscopic approach or a laparoscopic guided PCNL. That would reduce the chances of vascular injury. And another thing is, what I showed in one of my slides is, usually the ureter is high riding in cases of horseshoe kidney. So ischemic stone, usually they are non-obstructive. So if it's a non-obstructive stone, asymptomatic stone, it's very difficult for you to reach. Maybe you may have to abandon the procedure as well.
Dr. Sanjay sir, do you have any tips for the ischemic stone? Dr. Sanjay? Your mic is... Yeah.
See, in such situations, how I plan is, instead of going through the upper pole, I prefer to go through the middle pole. Usually these horseshoe kidneys are hydronephrotic at some degree. In those situations, if you use the miniaturized scope with the 12 French or 9 French, you can easily manage to go there. I had a paper, first mini PCNL on anomalous kidney stones in Journal of Urolithiasis. I had around 55 cases. Of all these cases, we could achieve almost 100% clearance, stone clearance in horseshoe kidneys. So mini PCNL has a high maneuverability. You can go to different calyceal system, especially in hydronephrotic kidneys.
Thank you, sir.
Thanks.
Dr. Robin, Dr. Prem wants to ask you, what about doing sandwich treatment? That is RARS plus PCNL in supine position. I think sir wants to ask about ECIRS and
Yeah.
Thank you, sir, for the question. I've already said in my slide that supine PCNL ECIRS is being favored. And the theme of my presentation was PCNL in orso kidney. The management of stone in orso kidney is not different than any other normal kidney. So we can go for, if it's a big stone, if it's a difficult stone, we can go for RIRS plus PCNL in supine position ECIRS, or if it's a big stone, we can go for a second relook PCNL after putting the nephroscope, or even in our cases, in our cases for the last 4 years, in those we had a clearance rate of 87.5% in our first attempt, but in the second attempt, we either went for relook PCNL or second look RIRS sandwich treatment. So with that, we had 100% clearance within 4 weeks. So that was the theme of my presentation. It's not different than any other nephrolithiasis treatment. Thank you, sir, for the question.
So would you prefer an ultrasound guided or a CM guided puncture in horseshoe kidney?
We are exclusively doing CM guided puncture in horseshoe kidney, so I would prefer a CM guided puncture. But like I said, it's not different than any other nephrolithiasis. Those who are expert in USA guided puncture, they will say this is better. I will say CM guided puncture is better. It is debatable.
No, Dr. Robin, I have a different opinion in this. If
Yes,
you
sir.
expert in both CM guidance plus USG guidance, if you are expert in both technology, many people, they prefer
USA guided. USA guided. Exactly. We can go directly.
If you are expert only in one method, definitely you will choose your method.
Yeah. If you are expert in both the methods, we will go for USA guided, because the calyces, they are facing dorsomedially, so we can directly go into it's very superficial, so we can visualize the calyx very easily. We can directly go into the calyx. If you are expert in both, USA guided, but in our center we are doing CM guided puncture.
It's always helpful to have an ultrasound machine handy there.
Right.
Even Sanjay mentioned, if you want to puncture the middle calyx, you can just keep the probe and make sure that there is no intervening bowel or something there.
Right. One of the difficult situation in this is aberrantly placed bowel. So a USA guided puncture would be very helpful in this case.
Sanjay sir?
Yes, I think especially in horseshoe kidney, mini PCNL is the best because of the small caliber of the tract. You can have maximum movability in it becomes a roomy system in horseshoe kidney. So even sometimes the horseshoe kidney, these are lying deep down. Sometimes you may need a longer sheet. So when you use this small caliber of sheet and instruments, it has a high maneuverability. That's what I see.
So the next set of questions is to you, Dr. Sanjay sir. I would request Dr. Prem sir, if you are there, the first question is from you only. So, Dr. Prem sir, are you there?
Yes, I have seen the question.
Dr. Sanjay, my aim, probably maybe I have not explained properly in the question. My question is that while puncturing the kidney, whatever the method you say in the PCNL, where from go, the main thing is that if your puncture is perfect, your tract is good, everything is done. Even I do not believe in the size. Sometimes I'm doing 30 French PCNL, I'm doing 33 French of the PCNL, I'm doing 16 French PCNL, there is no difference unless you do a proper puncture and the good tract. My question is that you were talking about the bleeding due to the vasculature, or different vasculature in the kidney, and you are neither doing the triangular technique nor the bullseye technique. You are doing this gradual descent technique.
Yes.
Yes, just like the Escapal does it. So in such situation, how you can prevent the vascular injury?
You see, I have shown you one video with the 3 calicial system. Have you noticed that in my
Yeah,
PowerPoint?
no, I did it because
Yeah.
in this puncture unit, three
Usually,
cases puncture, at that time you do not see the vessels.
no, you don't see
In
at all. But
yeah,
at the top of the pharynx, that is the least vascularity where you see the vessels. You have the least vascularity at that point when when you can make a puncture from the pharynx of the kidney. So I usually do puncture at 2 angles. First at 0° to see the depth, then turn when my needle tip is close to the pharynx, then I turn the CM at 30°. When you
no,
are
it means it is
puncturing,
triangle. Yeah, okay.
when you are puncturing at this level, at the level of pharynx, there won't be any massive bleeding. You won't be hitting any major vessels.
Okay,
That is the idea.
thank you.
So, sir, I wanted to ask you that when compared to conventional PCNL, are there any specific risks of mini PCNL per se?
So I have my own guideline. Okay, I do only in limited cases of conventional PCNL. That is when there is a bunch of stone like 7 mm, 8 mm. In my routine practice, I make an 18 French sheet. So sometimes when you are doing PCNL, you may have the bunch of stone of 7 or 8 mm. Then I will choose for conventional PCNL. I do not have to fragment all these stones, right? That is one condition. Another condition, when there is a stag on stone with the thin parenchyma, though it's working, in such condition, I use conventional PCNL. Okay. And I use laser in such cases because there is a very high chance of extravasation of stone out of the system in those conditions. So these are 2 conditions I prefer to use conventional PCNL. Otherwise, less than 1% I do this conventional PCNL in my routine practice. Most of the cases I do with the mini PCNL technique.
As you know, from the major manufacturers, there are metallic sheets available. But
No, I prefer to use these facial dilators, the one I have shown. I'm not sure whether I played this video.
Is there any disadvantage with the metallic sheet?
Sorry?
Is there any disadvantage of the metallic sheath? Why do you prefer the Teflon ones?
No, that is too stiff, very hard. When you are not in the pelvic calyceal system, it may cause the massive bleeding. But if you use these facial dilators, you go advance gently, it does not cause much trauma and wear and tear of the tissue. This metallic, I feel it's too dangerous for me. Maybe some other people they have their good experience with the metallic.
I think the advantage of a metallic amplast sheath will be when you are doing a lot of those maneuvers, it does help your protect your scope. If you see the wolf scopes or the mini nephroscopes, they tend to like get curved very soon. As soon as start using and doing all those maneuvers, they tend to curve more frequently with this plastic access sheath and plastic as compared to metallic sheets, in my view. I think that's the only advantage you get with the metallic tube. Otherwise, I don't think there's much difference in
And I
using.
want to add here that even the Carl stores have supplied their 15 French nephroscope with the metallic sheath.
See,
Yeah, we use with the metallic
I'll
sheath.
say one thing. If I use metallic sheet that has a fixed length, right? But if I use this black one sheet, I can advance the inner tip of the sheet to the level of renal pelvis. What I do, then the longer part of the sheet, I will cut it so that the tract length is short, because that is very important in mini PCNL, as stone evacuation is done by means of irrigation. You got my point, Dr. Tanuj. So I try to make shorter length of the tract. But if you have a metallic, it's a fixed. You cannot cut it. You cannot adjust it.
Some of us feel that because the plastic sheet will be, it can bend.
No, it's not a collapsible. It's a radio opaque, very nice one. Even you can get them from Cook company also. These are peel away sheet. Once you have the inner end of the sheet in the pelvic calyceal system, you just peel it away and you can make the short end the length of the sheet. And stone evacuation after dusting is much more faster with the irrigation.
Thank you, sir. So the next set of questions is to Dr. Bhojraj. Are you there?
Yes, I'm here.
So what are your suggestions to the practitioners, the people who are working in the field, how do you prevent urosepsis in a routine case?
Yeah. First of all, primum is urine culture.
Yeah.
And correctable risk factors for urosepsis you have to correct, like uncontrolled diabetes mellitus,
so
then active UTI, all those things we have to correct. Infection, of course, UTI you have to correct. Even colonization itself we have to correct anyway. Then choosing the proper antibiotic prophylaxis. That should be given before 1 hour now. Previously concept was half an hour, but that should be within 1 hour. Based on again the practice and antibiotic stewardship program of that particular hospital. And always know about which type of box are running in your setup, because it varies from center to center. That we should be always aware of the thing. And then intraoperatively, of course, whether you are doing RIRS or PCNL. For RIRS, again, the pressure within the PCS system should be as low as possible. Excesses should be used if and when possible, and operative duration should be shortened as far as possible, because crossing the time more than 60 minutes in children and in adults more than 90 minutes can significantly increase the chance of SIRS and sepsis. Now coming to PCNL, again, good puncture, proper tract dilatation, and then not harming the pelvic calyceal system much. That itself will reduce the intravasation of the endotoxins and then bacteria. And again, keeping the pressure low there, using the sheath, the space between the ampla sheath and then this nephroscope. Always we have to check that whether fluid is egressing out or not. That we should always keep in mind. And I think these are the main steps. If you find some pus or something, you are fishy thing, then purulent things, always better to stage the procedure. Just put a small nephrostomy tube, decompress it, and you can always go after few days. Send that for culture and sensitivity again, because pelvic urine culture and mid-stream urine culture, all of us know that the organism grown are different, and even that's why we have to send this culture as well from this pelvic calyceal system. There are few of the literatures that mention that sending intraoperative stone fragments and pelvic urine for culture and tailoring their antibiotic therapy postoperatively. Also few literatures are there, but guidelines are not that strong. But especially in matrix stone, we prefer for sending for the culture, because they have high bulk of matrix component with lots of bacteria hidden inside that, and we can send that for culture as well. Thank you very much.
Can I ask one question to Bose?
Yes, yes, sir, please.
So my question to Bhojraj is irrigation system, or the way you irrigate, is a correctable factor to prevent sepsis in RIRS? If no, why? If yes, how to prevent? How do you modify the irrigation system?
Yeah, so especially for RIRS, irrigation with large pumps, continuous irrigation with high pressure, that increases the phyllovenous, phylolymphatic, and phylosinus reflux, and that is one of the culprit for SIRS and sepsis in RIRS. So continuous irrigation with high pressure in RIRS should not be done as far as possible. Good vision is required, but with optimum pressure. Now coming to irrigation system itself, how to modify this irrigation system. Intermittent irrigation system is one, if and when required, with Pathfinder or others, or you can go with the larger, like we have TUR set for irrigation. You can connect that to the normal saline 1 liter bottle, and by gravity irrigation, roughly around 60 centimeter of height, we can manage some vision and all those things. But it's really difficult to optimize these irrigation systems. What is your opinion on it? You can tell me better about this aspect.
Yes, I think you have mentioned it correctly, and what we believe is irrigation really matters when it comes to
obviously, yeah.
post-operative fever in RIRS, especially when you are not using access-it. So what we think is if you run your irrigation under gravity, we use around 40 to 50 centimeter from the kidney height of the patient. And we use Pathfinder or Traxafro intermittently when we lace the stone or when the vision goes out. So don't use, pressure bags or pump that we use for PCNL. Don't use it for RIRS. And as you correctly mentioned during your presentation, watch for the outflow of the irrigation from access. That's very important.
That is most important, because
very important.
Smallest access sheet for flex X2 as 7.9 friends we get is the 9.9/11.9. As far as possible, if if new brand, then something larger than that access sheet will also especially help to vent out the intrapelvic pressure during the procedure. A bit bigger size of the access sheet.
Especially beginners, when the vision is not clear during RIRS, we tend to squeeze the bag or we tend to increase the irrigation flow, which is not recommended actually. So keep calm and just irrigate with normal flow, normal gravity flow throughout the calyces, and within 1 or 2 minutes the vision gets clear. So the irrigation is one of the most determinant factors for developing postoperative fever and sepsis after RIRS.
Thank you very much.
Thank you.
So the next question is, if a patient has a decompressed system by a PCN or a DG stent placement earlier, maybe for sepsis, one, is it mandatory to have a sterile culture before the next surgery? And what do you do if there's a persistent growth in the cultures?
Yeah. So this is very, very important practical question. Whichever has said this is really important, and thank you for the question. Now, once you put PCN or DG stent, it is recommended, it is not mandatory to have the urine sterile before that, because these hardwares are going to bound to colonize with these organisms, and until and unless these hardwares are there, we may not be able to make the urine perfectly sterile. What we can do is that, what the guidelines mention is that if there is a significant bacteriuria in culture, administer antibiotic according to the antibiotic sensitivity pattern, approximately 2 to 3 days prior. I practically prefer 3 days minimum, and let all the endotoxins and bacteria to the level, the colony to go down. It's not sterile still, and then we can remove those hardwares, and then we can go ahead. But keeping in mind that these patients are more prone to go to sepsis again. Intraoperatively, also all the precautions we have to apply. Followed after that, also we should be very, very vigilant to detect the SIRS and sepsis on time. Now, post-operative.
I think it's disconnected. Okay, I think we can move to the next set of questions till Dr. Bhojraj comes back. So, Dr. Bipendra, are you there? Or am I disconnected? Hello?
Yeah, I'm hearing you.
Yeah. So, next set of questions is to you. And you have answered it, but because it is important to get this message across, what should be the investigation of choice in case of a post PCNL bleed?
So the most important line I want to state is that you need to investigate. Okay, the choice is between whether you want to do a CT angiogram or conventional renal angiogram. That is the main question that I think most would want to hear. So which is best? For the diagnostic point of view, for diagnosis, conventional angiogram has the best sensitivity with regards to diagnosis. However, when you talk with a radiologist, they would always want to prefer CT angiogram. Why? Because number one, it's available all the time. Anytime you can do it. It's not operator dependent. And because once you see a case in CT angiogram, you see a aneurysm or a AV fistula, then it gives the radiologist time to plan for the equipment. As you know, in our center, like most of the centers, you don't have embolization coil, all sizes of coils and everything are ready. So what they prefer is they get a CT angiogram done, they plan what the case is, then get all the equipments ready and do a conventional angiogram in a second phase. So if you tell me now what would I do prefer to do at what would I my radiologist would prefer to do is a CT angiogram is the investigation of choice in an acute setting in most of the cases. Then you can plan for a conventional angiogram. But if you don't have a CT, you have a conventional angiogram. This is well and good. You can directly go to a conventional angiogram if your radiologist prefer it, and go away with embolization if and when required.
Dr. Prem, sir, what is your take on this?
Pardon, please.
So what is your take on the choice of investigation for a post-PCNL bleed, sir? With your vast experience, what would you recommend should be the choice of investigation for a post-PCNL bleed?
No, post-PCNL bleeding, and if we are planning for the embolization, it will be ideal to go directly with the embolization, not to have only have the investigation report. Prepare for embolization and go with the all armamentarium, all the equipment and coils, everything for the embolization. At the same time, you can do the angiogram, find out the aneurysm, pseudoaneurysm, and at the same time, you can embolize it. If you are going for the CT angiogram first, and nothing extra benefit you will get except the time to arrange all these equipments, and again you should take the patient for the intervention room. So I would prefer to go for the conventional angiogram with the preparation for the embolization at the same time.
So basically, just to add to it, it basically depends upon what your radiologist prefer rather than what our surgeon prefers in this case.
So if you're waiting,
yeah.
Otherwise you can, you will.
In my opinion,
Sanjay sir,
yes. In my opinion, if you suspect this patient is bleeding repeatedly, and if you think this patient may require the embolization, I will go with, as Professor Prem said, directly go with the cath lab and plan for the embolization. See, our patient, they travel a lot from the remote areas. Not all patient can afford for CT scan and repeat for the embolization and all. So if you suspect if you think this patient need embolization, I will directly go with the embolization.
I think that answer is well taken.
Yeah, small difference that those patients who have deranged renal function test with bleeding, then definitely we want to give less amount of contrast as far as possible and manage the bleeding as well. I think straightforward conventional angiography is better. Otherwise, CT angiography really gives a good roadmap. Not only bleeding, some suspected complications also we can rule out. Rather than these two supplementary, they should be complementary. This is my feeling, except in those patients with who need to give less amount of contrast, then we should go for directly for embolization. What do you think, sir?
See, in my opinion, CT angio is helpful. I had to do 14 cases of super selective embolization. Out of that, 2 cases, we were having bleeding for long duration, almost 1.5 months, 2 months. When I planned for embolization, we could not detect in the cath lab. Then in those 2 cases, I had to repeat the CT, which gives the good road mapping, and then again I had to plan for the embolization. So this my experience, what I felt in my cases.
Thank you, sir. Dr. Bipendra, do you think there's any role of diuretics in a postoperative bleeding?
No, there is no documented data for the role of diuretics in preventing or decreasing postoperative bleeding as such in literature. So I don't think there's any role.
Dr. Sanjay sir, what is your take on that?
No, I don't have. I didn't say any paper on this. The role of diuretics.
In practice, do we use diuretics? No.
No, the role of the diuretics is only there when there is a lot of extravasation during the PCNL. Not to stop the bleeding, just to wash out the fluid which is in the retroperitoneum. Only for that purpose, single shot of furosemide may help. But furosemide doesn't stop the postoperative bleeding. It is not proven.
Thank you, sir.
Tanuj, there is a questions in the floor for Dr. Bipendra. What is selective and super selective embolization?
Basically, I talked with my radiologist about this just yesterday, and this is just a terminus that's used. Most of the embolizations are super selective as such. So selective and super selective, though there's no hard and fast difference as per that. Super selective is when you are basically selecting a specific vessel rather than selecting more proximal vessel as compared. So if you have a bifurcation and you have a aneurysm at beyond the bifurcation, and if you can reach in beyond the bifurcation and selectively embolize the vasculature containing the aneurysm, then probably there is more super selective embolization. Sometimes that may not be achieved, that cannot be achieved, but still if it's a peripheral vessel, but you are embolizing it before the bifurcation, then you may also embolize some of the smaller vessels, then probably that would be called as a selective embolization. But as per them, it's more talk about super selective embolization is present in literature, though there is no exact definition what is selective or super selective.
And this is my questions to Dr. Bipendra. So though this embolization procedure is carried out by our radiologist counterparts, since the procedure or the complications are done by us, so we need to do some counseling. So how often do you counsel the patient about kidney loss when you send, before sending the patient for embolization actually? Do you counsel them, or is it necessary to counsel them for kidney loss, ipsilateral kidney loss or not?
Regarding the data with ipsilateral kidney loss, as of now, the recent advanced technologies, the percentage of kidney loss is negligible. They have done DMSA studies where they have even not found post-embolism scars when super selective embolization was done. So for purpose of embolization as such, counseling regarding kidney loss, we do tell it prior to PCN. What we tell them is prior to PCN is that number one, there are three things can occur. Number one, bleeding can occur. Number two, you might require transfusions. Number three, you might require embolization. And if it is not at all successful, then you may require nephrectomy.
My question is,
I'm going to that. So prior to that procedure, we usually counsel even about nephrectomy. But when going into an embolization shoot, we tell them that embolization is successful in majority of the time. Okay, majority of the time. But if at all it fails, you may require an open surgical procedure, which may include nephrectomy. So we do tell the patients, even when they go to embolization shoot, that it's not 100% successful, but if at all it's not successful, then you may require nephrectomy or open surgical intervention following that.
Thank you.
So thank you for the excellent discussion. If there are any other questions, Dr. Anil, we can take those.
Thank you, Tanuj. I think we have covered majority of the questions.
And if there are any further questions, I would request all the speakers to please go to the chat box in the ULTO group and answer them immediately.
Definitely. Sure.
Thank you, Tanuj, and thank you, Nitesh, once again for providing us this platform. And we'll be in touch. I think it was interesting. I don't know actually how many people saw this program live. Anyway, thank you. And thank you, Anil, also for organizing this forum and continuing future also.
My pleasure, sir. My pleasure.
Thank you, sir. Thank you, Team Nepal, for an excellent and wonderful presentation. We, on behalf of ULTE, are overwhelmed and wholeheartedly thank you all for sharing your knowledge. I thank each and every faculty, Dr. Prem, Dr. Sanjay, Dr. Vijay, Dr. Bipendra, Dr. Robin, and especially Dr. Anil for coming forward and organizing this academic feast. Thanks one and all. Thank you. Thanks.
Thank you,
Everyone.
Nitesh, and thank you, Tanuj.
Thank you, Nitesh.
Guys.
Thank you, Tanuj. Thank you, guys.
Thank you. Bye-bye.
Bye.
Bye. Thank you.
Thank you all.